at home, and also we welcome our media fraternity in this briefing on our plans to combat the spread of the coronavirus. We also welcome my colleagues, to Dr. Cyril Ramaphosa, and who's our Minister of Health. We welcome the Minister of Social Development, Minister Lindiwe Zulu. Thank you, colleagues. Hopefully other colleagues will join us. Without any further ado, we will ask Minister Cyril Ramaphosa to speak to us on our plans arising from what the President said to the nation yesterday. We are elaborating further on what the President said and the guidance that he gave us yesterday. But we are keeping the nation posted on what are the measures we are taking to combat the spread of the virus through the wonderful mouth and expertise of our Minister of Health, Minister Cyril Ramaphosa. Minister, the opportunity is yours.
Thank you very much, Minister Mthembu, Minister Zulu, and all the colleagues, members of the media, and fellow South Africans. We are here largely to elaborate on the issues that were raised by President yesterday as the guide to what we should expect or on how we should manage the situation as we move forward. It is also important to indicate that there's been lots of discussion at various levels in the health leadership, which we call the National Health Council, in the ministerial advisory committees, and in the cabinet and different clusters. Last night, the President addressed the nation to outline our national response to the increasing spread of the coronavirus across the country. As health, we have come to give clarity on these matters. Firstly, I want to assure you that the decisions that have been taken have been through a lot of consultation. As the health team, we have also got regular consultation individually on a bilateral basis, but also as a collective. At national level, we receive these reports which give us the latest update. Every province gives us 2 or 3 reports every day. The one set of reports is the status of everything that's been done, and then of course challenges and mortalities also come up, and therefore we monitor the movement of the infection across the country every day, and every day we receive the report from the National Institute for Communicable Diseases, NICD, and then of course whenever there are special meetings we then have those discussions that will give us additional information. But in between, we also consult with the different departments depending on the issues that need to be attended to. So at some point it would be about mining, it would be about education, it would be about transport, it would be about social development, it would be about science and technology, and so on. The level 3 regulations that were gazetted on the 28th of May set out 10 district hotspots, and these included 7 metros out of the 8. But as it stands now, on that original definition which we had put up all the 52 districts can now be considered as hotspots. This, of course, is telling, and if anyone would have doubted the aggressiveness of the pandemic, I think we should be aware that it's time to really, wake up and really take notice of that. It's spread all over the country, and the numbers are growing every day, and the hospitals are admitting patients each hour. And some of our loved ones don't even make it to the hospital, and they unknowingly get infected, and some fall ill and some do pass. And as it turns out now, many of us have got friends, relatives, family members who are already affected by this pandemic. So it is a new painful reality that we can only curb this viral infection through if we as citizens behave. And it's a choice that we have to make as South Africans for the sake of our own nation, our own friends, our own selves. And so it is important, therefore, to indicate that we need everyone to begin to take responsibility and change behavior and make sure that the approach we take ultimately assists the whole country in trying to stem the tide of the pandemic. So the president yesterday announced a number of restrictions which are being imposed whilst we're at level 3. We did indicate, excuse me, in the past that we will actually be putting additional restrictions where necessary, and this is the context around which the president has made these particular announcements. We have had a consultation with the Minister of Transport dealing with the issues that relate to the taxi industry. I think it's important for us to indicate that for all our people, the original lockdown, whilst it was very helpful in delaying the arrival of the surge and gave us a bit of time to be able to prepare our health services, it did have its challenge that we knew it would not be sustainable. It would be important for us to consider the issues of food security, income security, and ensure that people are able to get their regular income. Because though there was some work done to provide social grants and various other grants for our people, but it is not possible that everyone can live through those grants, and those grants cannot be sustainable forever. And therefore, it was important for us to take this into account, that we need to now balance the lives and the livelihoods, and therefore get our people to learn to coexist with the virus. We also knew that the numbers, as we had indicated, were going to be rising, and it's important again that we did indicate earlier that the surge was expected to have come out from around June, July, and towards August. But because of what we went through, the first lockdown, it has been pushed further to around July and August and towards early September. Excuse me. Now, part of what we had to go through is that for our people, the mainstay of transport are taxis, which transport very close to 16 million people every day on a normal a day when the economy is working properly, and therefore it becomes the one very, very important aspect in ensuring that people can get to their jobs and be back home safe, as it were. So we had to then take a number of studies to take into account what is the best way of assisting as we have to get our people back to work during this time. Now, some studies which were done in China indicated that the virus spreads very quickly between people sitting in a confined space for more than 20 minutes. So that becomes the issue. It also showed also that in some of the cases, the air conditioners that are cycling air inside the room can actually contribute to the spread of the infection. There were also now these other concerns about the virus being airborne, but this we are aware that there is quite a lot of debate at the WHO level that there is such a possibility, and that some work is being done at that level. But what we also found was important was the importance of the ventilation in reducing the spread of the infection, that if we were able to allow the movement of the droplets through allowing a draft in a confined environment, this actually assists greatly. They've done a number of experiments showing how opening windows and allowing a movement of air actually has been helpful. So a lot of issues therefore had to be taken into account in this case, and part of what had to be looked at was what would be necessary to sustain the movement of the taxis under all the factors that have been considered by the Department of Transport, just specifically as objective evidence done based on studies done by the Department of Transport. Ideally, the ideally is to get for every taxi, not there must be no people who are less than a meter apart, and of course those who are in front shouldn't have people behind them very close. But that is an ideal situation which doesn't exist in the taxis. So we begin to see the need now to put in mitigating steps to try and assist in that situation. And so in these steps that had to be taken into account came therefore the recommendation that for long distance we recommend the 70% occupancy, and that where in the short distances where anything less is not possible, then we put up certain requirements for 100% capacity. So these are some of the issues that we've had to put into place. That drivers and conductors should complete a daily symptom check before being allowed to go into the taxi, which effectively means what we normally do to screen people. We need to make sure that drivers and conductors should be free of symptoms as they go to take the taxis. The drivers and conductors must at all times wear masks and keep them with them for the duration of that particular trip. That when they are out of the taxis, the drivers and conductors must also keep social distancing so that they are not also crowding together. They must always be standing far apart, even that is specifically when they are outside the taxis. But that the windows should be opened, and this is sufficient to be able to allow the movement of air so that the whatever air particles or droplets might be inside are able to move out of the car. Therefore, they move from one side of the window through the other side. This does not require that the window must be widely open. It's got a certain amount of opening, which is a slight opening that we encourage, that we actually can create a stopper that will make it easy for drivers to know that the minimum really that is needed is not like the full window must remain open. So it is understandable that we'll all be concerned with the fact that it's very cold winters, but the size of opening of the windows should be sufficient to just allow the movement of air so that it can drain out those droplets from the the car. But of course, the other issue that is important is that the taxi interior and surfaces, such as door handles, should be wiped down at least once a day, so that if there could have been any contamination, it should be wiped away. Now, outside also, when people are waiting on the queue, where distancing is possible, then of course we should be able to make sure that people stand further apart at that level. But it's also important to say that no person should be allowed into the taxi without wearing a mask, and we have indicated that the mask doesn't mean we must all all wear a 95 mask. We basically can create, our own homemade cloth mask, which we can put up there. I'm making this point in particular here because we expect at any one time, even with the Minister of Transport, we've got one set of protocols that is now operating. We have addressed the Taxi Association and indicated to them the importance of why they have to actually keep to the particular protocol. And they did appreciate the fact that they were at least now being taken on board to understand exactly the mechanics of the spread of the infection and what needs to be done to prevent the virus from spreading. So that basically, if I could leave it at that from the point of view of the taxi operations. The second issue relates to the alcohol restrictions. I think here many people might have kind of been taken by surprise by this issue, but I think it's important also to say that there's been also many people who have welcomed and supported this issue of the suspension of the sale and distribution of alcohol. And when we look at this, at the end of the day, it's more about the limiting the damage that each particular set of circumstances tend to create. Now, we are very concerned about the fact that the consumption of alcohol in the country is pretty high. Well, it's estimated that 31% of South Africans 15 years and older are current drinkers, or they must have consumed alcohol in the past 12 months. This is a WHO Global Status Report, which was done in 2018. Despite the low proportion of South African adults who drink, we're one of the countries that drink the most, and in the WHO Afro region, at 64.6 grams of absolute alcohol per capita per day. That's about 5 and 6 standard drinks of 12 grams absolute alcohol. That's about 15 meals a day. Now this, it's important because it's higher. The average in the other countries is 40 grams per drinker per day. And so that's a matter of concern, that it's actually a matter of record. Almost 6 out of 10 drinkers over the age of 15 in South Africa are reported to engage in what is called binge drinking, that is high episodic drinking. In 2016, alcohol attributed trauma deaths exceeded deaths attributable to alcohol-related liver cirrhosis and alcohol-related cancers, respectively. So it's not only just the damage in terms of some of the related accidents, but also there are other conditions that are associated with alcohol in terms of the damage to various organs. We were moving around during the course of the week, and one of the professors from Steve Biko was indicating a very sad situation that alcohol-related trauma patients are usually young, fit individuals who would not otherwise have needed to be hospitalized. But because of the accidents, then they are there and they need to be given attention. During the level 4 and level 5 lockdown, a study done by Perry and others showed that there was a 60 to 70% reduction in trauma admissions because of that lockdown at that time. Conversely, when the alcohol restrictions were lifted during the level 3, Facilities reported up to 60% of increase in trauma emergency center admissions and up to 200% increase in ICU on trauma admissions. So some of the modeling that was done to predict the impact of an alcohol ban, and these models was demonstrated that introduction of a suspension of alcohol sales could result in 20% reduction in all trauma and 40% reduction of all alcohol-related trauma by the third week. So when we get into the surge and we require more of our wards to be available, it therefore means that the real problem, and many of us would have seen how in the media, some of the staff or health workers have indicated the pressure that is caused by the admission of patients with trauma. The problem with those patients is that basically breaks the routine in the hospital management of patients. If somebody comes and is bleeding, you have to drop the person who's sick and go and deal with the one who's bleeding because it's an emergency. There are a number of instances where, in fact, you have to even stop theater and rush in someone who is having a trauma because of the nature of the bleeding, just to be able to save lives. In some instances, when you deal with, for example, someone who's got a stabbed heart, literally everything freezes and everybody will run into theater even before they are fully scrubbed, and that's the nature of the disruption that comes with the level of emergency that is created by the trauma. So these particular individuals will move from theater to ICU and therefore demand attention from a large number of nurses and equipment. Now, we need those right now to deal with people who are coming with COVID-19. And therefore, to be able to create space for those individuals, we need to then make sure that we can limit the numbers of people who are coming in because of the trauma. I've even seen on, excuse me, I've seen on the social media a number of people who have posted, who are health workers, who have just been frustrated by the sheer disruption that is caused by all of those patients who come in as a result of the trauma. And so I think our people need to understand, therefore, that we're trying to balance everything here properly. Alcohol is a big factor in a number of people who would have come in with motor vehicle accidents, gunshot wounds, and penetrating wound injury, which ultimately results in a lot of attention that is needed at that point. So this is the reason why we believe that during the surge, we need to actually focus on one set of problem, and that is the increasing numbers of those who are coming through. And they will be needing urgent attention, and we shouldn't find anyone coming in and only to find that the beds are blocked by people that could have really been saved from the accidents that brought them to hospital. So we have also had various comments about this issue, but all we're really saying is that we plead for understanding and for patience as we try and navigate through a very difficult time in the country. And this is one of the issues that we think at the end of the day it would be inexcusable to actually end up with beds blocked by something that's completely preventable and avoidable as the consumption of alcohol, and then end up with the lives of people with a difficult viral infection being compromised. We have also heard that some people were using some other concoctions and home-grown stuff and so on. However, that did not show us too much impact at the time we're going through the previous lockdown. So we'll monitor if there's anything else that's coming through causing us a problem. The other point which has also become important is that we have opened the economic activities largely to save our people from the problem of income insecurity, loss of income, unemployment, and also to make sure that there's food security for those whose sectors are able to continue operating. But for everyone who's going through a workplace, now if you can imagine that you come to the taxis or to the public transport, there's a strict protocol. If you go to the public places, there's strict protocol, and everywhere we go, there's a clear protocol as to how we can social distancing and how to prevent infection using the masks and so on. But that a lot of activities take place outside the workplace when we start to socialize, and a lot of accidents do take place at night, in the evenings, and also some of the activities that have brought us a lot of concern have also happened in the after hours when people go out and socialize, where they congregate in very congested spaces and sometimes with or without alcohol. That has also been part of the problem. And when we looked at the experience in China, about 75% of the infection actually spread through social and family gatherings of that nature, where people were gathered in large numbers afterwards. And so when we therefore recommended that there should be a curfew, it's also to assist to limit the numbers of people who get infected in the process. Let me also say that whilst those numbers, we expect those numbers not to increase, we do expect that the numbers are going to be higher anyway because of the surge. But the extent to which the surge is going to grow does depend on how strictly we also still practice some social distancing. It's not inevitable that whatever was predicted is actually what's going to happen. And so we can actually have the surge at a lower level, even though the peak is now, but it may not necessarily be at the worst pessimistic scenario. So these are some of the steps which we are taking to avoid the surge arriving at a much higher level, but it's a very wide range of estimations that we're working on. There's the optimistic scenario where there's a surge with lower numbers. There's also a pessimistic level where there's a surge with much higher numbers. All of that depends on our own behavior, and that's what we're trying to manage at this point. And when we looked at our models, we found that they are getting better and better refined, and because of the new information, the real data that they've been able to bring on board. But that data has also indicated that the surge will come. It will come as expected now in July, August, September, but the estimation was that it is coming at a lower level than was previously estimated, which means that some of the infections that did not happen during the level 4 and 5 actually helped us to reduce the level at which the surge is coming. So if we don't manage this situation tightly, we actually are going to end up with the surge coming but going to the pessimistic scenario where the numbers are much higher than we had predicted. So it is therefore in that context that the issue of the curfew has been brought into place. The other point which I just want to mention, I'll do this briefly, is that when we moved from level 4 to level 3, we started indicating that we're changing the prioritization because we had been able to determine areas where we could see lower transmission and higher transmission at the point. We therefore shifted, guided by the challenges of the global supply of diagnostic kits. We then shifted to focus on specific targeted groups of individuals who are a lot more vulnerable, so that when we do the test, we prioritize those. So we therefore reduced the community screening, where we want to go out on people who had who had not reported in our institutions to test them. So we're focused largely on people who are senior citizens with symptoms, those with comorbidities, and those who needed hospitalization, and healthcare workers. We're doing this right across now. Sometimes I had people asking me, but Western Cape has changed the criteria. It's not Western Cape, it's the whole country that's changed the criteria, and it's an approach that we're doing just to make sure that there's closer and tighter management of this situation. And out of this, we also had to deal with the backlog testing, just to make sure that now we've reduced the turnaround time of all the tests that have been done to make it easy for all the patients under investigation and those who are needing treatment to be attended to within a shorter space of time. Hence, the President was announcing that we need at the most to try and get a turnaround time of about 48 hours, because some of the patients would be kept in the area of observation as patients under investigation, and that delays a lot of things if the test takes longer to come back. That's why sometimes you hear everyone say the beds are full. In fact, the beds are not necessarily full, but what happens is that the triage area has to keep someone until they know whether they need to go to a COVID negative ward or they go to the COVID positive ward. That delay sometimes would have been caused by the results having not returned quickly. So the 48 hours that the President was talking about was really referring to that aspect. We haven't yet reached the level of beds that we currently have, particularly at non-ICU beds. We have still got quite a lot of capacity, but the blockage we've observed comes from the triage centers, and therefore in a number of areas we've actually made sure that these centers are expanded. So in the past 2 weeks, we've actually gone on an additional provision for additional beds in Gauteng, particularly to be able to relieve this particular problem. And I've set up a special team, which is an emergency intervention team from National Office, which is now working with the provincial government to ensure that all the hospitals are able to absorb as many people with additional beds. So those beds allow for observation, and after that, of course, the person gets referred into the hospital depending on what the level of attention that they require. So part of what we are therefore explaining is the issue of targeted testing, that it is important as we manage the patients. But it's also important to make a point that in the whole world, they've found that there's quite a large number of people who are positive, COVID positive, but who, okay, let's put it this way, who are infected but have got no symptoms, and therefore would not necessarily have come through for testing. So at any one time, the numbers that we've got of people who are positive will not necessarily mean that everybody has been accounted for who could have had the infection, because of the large number of people who get easily infected and recover without even showing symptoms, and some have very mild symptoms, and so they would actually end up disposing of the virus very quickly without any sense of unwellness being detected on their side. Now that basically means, therefore, that's why it helps us to work on the models now that are giving us focus of what possibilities could be. And this is happening in all the countries. And when we do the estimations, we estimate based on the experience that everybody else is experiencing in the whole world. We still want to emphasize the need for isolation and quarantine. We believe that this is important. We have found in some of the instances, particularly as we're dealing with this in the Western Cape, but we're picking it up in a few other areas, the question of people who are reluctant to be subjected to voluntary quarantine. Some of that has got more to do with the anxiety people have about what it means to be admitted with COVID-19 or suspected of having COVID-19. The others is because of the stigma that people fear this infection. What's a new infection? So we do want to thank all those who have come out and have indicated that they have recovered. They've actually are ready to support the others. So those who have set up the support groups on Facebooks, on WhatsApp groups, and so on, we want to really thank them for that, because it's important for us to realize that, you know, this is going to be part of our day-to-day reality now, that we must be able to embrace people, support them, and encourage them for testing, encourage them for quarantine, encourage them for various other things. In some of the cases, people fear that they will leave their homes and they might be burgled into. That's why we have a call now for, in every ward, there should be, COVID forums, COVID-19 forums, where the community leadership and volunteers must work together to give support to those who need to be given attention for the management of the virus. So it's important as well that in some of the cases, people would like to continue with their life. They want to know if they can go into a quarantine site and continue smoking or drinking and so on. Of course, we couldn't encourage that, and so then you find that there's reluctance at that level. But we have to stress the fact that that still remains our major weapon in fighting the infection, the continuous isolation and quarantining of the individuals at that level. We will later this week also announce a change in the numbers of days for quarantine, because we continuously update our situation, and we think it's important to know that there are very mandatory days where the quarantine would really be important, and then after that we should therefore understand that the nature of the infection is such that once you've gone through that process, you are safe to go out and mix with the rest of society. But also important to raise the fact that as we are dealing with the COVID-19 situation, there's a whole lot of other comorbidities, other diseases that require similar attention. So the issues of tuberculosis, HIV, diabetes, blood pressures, cancers, we continue to manage those situations. It becomes important that people must continue to get their treatment from the hospitals, so that they are able to manage and keep those diseases under control. It is important as well because we have noticed that during the lockdown there was a reduction in the numbers of people who were coming for testing for HIV, for TB, and immunization and some of the basic essential health services. So we need to get that corrected, because we are going to live with this infection for a longer time. But at the same time, we also know that the other causes of ill health, the other diseases, are still as important. They will still cause, morbidity or death if they are not controlled. So we cannot behave as though all we have is just COVID-19 only. We need to keep that balance. The balance is important because COVID-19 becomes more opportunistic on those whose control is poor on the other diseases. So at the moment we are aware that we've got 8 million people who live with HIV in this country, who must be under control, who must be virally suppressed and be on treatment, and that must be continuously monitored. We've got 4 million people who have diabetes, who must be diagnosed, who must be treated, who must be kept under control with or without COVID-19. It's also known that 1 in every 3rd South African suffers from hypertension. These I'm mentioning, particularly hypertension and diabetes, are actually some of the very important comorbidities that have been associated with those who have passed as a result of COVID-19. So we continue, therefore, to encourage our people to come through and be, treated for all of these conditions. Hence, when we go to hospital now, we keep the separation so that those who have the infection must be treated in a different part of the hospital, and those who have got no infection must be treated in a different part. The mixing is what we need to avoid, and that's why we continue to put additional beds to continue to separate the people out. This has been the approach everywhere else in the world. Then there's been a bit of concern about Gauteng. I think the real issue with Gauteng is even before the numbers were higher than those in the Western Cape, the real issue was the pattern in which the increase was happening. Gauteng moved from a very low number. At the beginning of June, there are about 230 positive patients recorded per day. By the time they got towards the end of the month, we were at 3,000, 4,000 people per day who were turning to be positive. And therefore, you felt that on the ground with the large numbers that were showing up in the hospitals. So the sudden increase within a short space of time is what really jacked the system in Gauteng. At the beginning, we had actually identified certain hospitals that needed to be given a focus as being the ones where the patients with COVID-19 would be treated. But it became clear with time that we need to open up all the hospitals to be able to manage, because someone will walk in and the symptoms won't be clear until they're inside to be able to determine whether they must be treated or tested for COVID-19. And then, of course, then we now have to suddenly increase the numbers of beds at that level. This is the team that therefore had set up the National Emergency Intervention Team that is now working around, and we're also looking at augmenting the work that was already done by Gauteng government to increase the numbers of beds, so that we must always stay ahead of the curve. The models that we're using have indicated that in almost all the provinces, probably except Northern Cape or Northwest, the rest of the provinces may actually breach the numbers. So because we've seen how the field hospital beds are being constructed, we actually are confident that we can provide a number of these beds ahead of time before the surge catches up with our hospitals. But when we originally spoke about the issue of hospital beds, field hospital beds, we were talking about them as additional beds, but increasing evidence in the process came in to indicate that those beds will be more useful if they've got oxygen reticulation. Now, that's a new issue that got built in long after we had established the numbers of beds that we needed to prepare. So already now work is being done to reticulate as many of these beds as possible with oxygen. And over the weekend, we've been talking to a number of providers of liquid oxygen to assist us, in particular Afrox, where we actually had to have urgent meetings to, even before those pipes are put in the rest of the hospitals, but that additional capacity is brought into various hospitals in the Western Cape, in the Eastern Cape, in KwaZulu-Natal, in Gauteng. Everyone is now busy working on that, so that there's early administration of oxygen for those who are coming in. This becomes very, very helpful, because in this case, it has been found that it's the hypoxia that becomes a problem, the reduction in the oxygen levels in the blood that becomes the first problem. But once you can counter that with administration of oxygen, then in the process as well, the use of dexamethasone, this particular drug that has been used in the past for brain edema in head injuries, for asthma, acute asthma, and other autoimmune responses. That drug, dexamethasone, is actually one addition in terms of the ammunition that we need to fight this disease. So those two now are making it easier even to start treatment in a district hospital. And so we're moving now to encourage more and more oxygen availability at that level. But we have also in the modeling noticed that means that the country doesn't right now have the same level of oxygen for medical usage, and therefore we have now been involved in these discussions to divert some of the oxygen from industrial use into the healthcare, and therefore also looking at how the production must be increased. There's work that's being done at that level, and we've got good cooperation from the companies that are producing oxygen, and of course the industry in general. So we would therefore say that those issues are for us key interventions that are making us to say to all our people that we are determined to reduce the numbers of people who are affected. But we also believe that it's important for us to understand that the extent to which the virus will spread from one person to the other is not something that can be solved by the hospitals. It is something that our people have to take into account. So those of us who will be venturing out of our homes without masks must know we're actually being negligent at this point. It's important to say, everyone, as you get out of your home, you have to wear a mask, and that's why we've insisted now that the owner or the manager of the particular structure that's offering the services must ensure that whoever comes in must be wearing a mask, and this will help us to make sure that we police each other, we monitor each other, we support each other to make sure that that change of behavior becomes important. In some of the instances, we have people who still want to continue having parties and situations where they mix irresponsibly. We would like to really discourage that, and we have heard now something which is becoming common of people who go to a funeral and then afterwards they do what they call after tears, whatever they call the gathering. It is actually a source of real concerns for us, and so I would like to discourage people from after the funeral. People need to dissipate, and they must move out of that family and not continue together, and even start having a kind of drinking or unhealthy social behavior at that point. It's also very, very important for us to ensure that we still insist on the limitation of the people on the funerals to a number of 50. Excuse me. At that, we have a number of people who can still record that they got an infection after they'd attended a funeral. So we need to understand that there's still a big risk with our funerals and the way we socialize. But either way, wearing of masks, sanitizers, washing hands, distancing still remains our major way of how we can deal with this. In particular, also making sure that we decontaminate and wipe all the surfaces where droplets could have fallen so that people should not be affected. We must also continue to protect those who have got comorbidities such as hypertension, diabetes, cardiovascular diseases, chronic lung diseases, cancers, HIV, etc. So all of those, particularly if they're above the age of 60, we have seen even people at the level of 50 years, also the level of mortality is rising at that level. It is also important to say that it would not be helpful for our people to be gathering in large numbers in the beaches. That's why the beaches have also been kept closed, so that we don't have the kind of interaction and congestion that can happen in the beaches, which we have seen during the festive seasons, that those kinds of activities are really going to be problematic for us as we trying to manage this situation. We have no vaccine, we have no cure. Although we are participating in the development of the vaccines, it's going to take us more than a year and a half to 2 years before those processes mature. There are a number of vaccines and trials that are going on at this point. All of them are particularly important, but they are not helpful immediately. And so even with dexamethasone, it's only used for those who have got the heavy reaction, particularly affecting their lungs and other parts of the body, that's where it becomes useful. But we don't want someone to walk around the streets and say, well, there's dexamethasone, so I'm going to be sorted. It doesn't work for those who have got mild symptoms, but it actually works for those who have got a very severe kind of symptoms. They call it a cytokine storm, which basically means it's the reaction of the body against the infection, which gets so huge that it begins to destroy the body's own tissues and makes breathing difficult. And that's where the dexamethasone becomes helpful. So the other one that has been put into, that has also been proven to be helpful is remdesivir, which is antiviral drug as well that can be used. But those drugs are also used for instances where people are already having severe cases and symptoms are also overwhelming. And that's therefore it's important for us to say our biggest weapon right now is behavioral change, is prevention, it's use of masks, is cough etiquette, is social distancing, is understanding that COVID-19 is real. It's also understanding that when we talk about COVID-19, we're not talking about something that the government must solve as government's problem. We're talking about something that's really caused lots of concerns and challenges and devastation in different parts of the world, but we are trusting on the behavior of our own people to be able to get us to defeat this infection. It is still possible that we can reduce the numbers of people who are getting infected, but we can never stop the infection because it's really not possible. But what is possible is to limit the pressure that this infection would cause into our own system. We have also taken advice from our ministerial advisory committees about opening of the schools. The same doctors who treat those children, the same doctors who treat all those who are sick, when they sit together, the professors, the scientists, they've actually said we need to open up the schools because we need to understand there's a need for us to coexist with the virus. We must know how to behave when there's still the viral infection, and the distancing has been the major factor. Distancing and masks and hand sanitizers and washing of hands, those have been the major weapon in fighting this infection right across the world. And because of that, it's important for us to understand that for everything, whether it's workplace, whether it's transport, whether it's schools, everywhere we have to shift and change the way that we've behaved. But of course, huge gatherings we still can't take, and therefore that's why it's been important to say let's keep those still closed, because those numbers, when we've got so much of congestion, it becomes a challenge. So we still have all those large gatherings not allowed at this point. So we do want to then say to our people, to all South Africans, that we have to work on this together. And each and every one of us mustn't think that it's up to the government. It is not up to the government, it's up to all of us working together. And also we will also want to encourage people to take up the issue of isolation and quarantine. That's the other part that you can play as an individual citizen. We have an ICT platform that will be talking more about as we go on, which is able to send you information about the results and also get you to declare all your contacts and so on. But all of this is to assist the processes of containing the infection. But it is not possible for the infection only to be dealt with by the nurses and the doctors. And therefore, in closing, colleagues, I want to also just pay tribute again to all the health workers and those frontline workers who have dedicated their lives in serving our people, who have made a difference, who have made all the effort to bring in the protective equipment to assist them. Even over this weekend, we've been dispatching some that has come from donations from Solidarity Fund to make sure that there is adequate protective gear in the hospitals, in the various workplaces, so that our people who are in the forefront can be protected. And this is important for us because they are the first troops in the fight against COVID-19, and certainly community has to deal with the issue of prevention, but management of those who are infected relies on the health services, the health workers, and those are our heroes that we must continue to salute and pay tribute to for the good work that they are doing. And we want to say thank you to them for the work that they've done. And we know that some of them have in fact succumbed in the process, but we must say it's a difficult time that we must go through together as South Africans. And to do so, we need to unite, we need to follow the guidance that our president has given. We need to follow the guidance that all the health workers and health professionals are giving. We need to work together as various aspects of society to make sure that we defeat COVID-19. Thank you very much.
Thank you very much, Kawazela. We will now proceed, and as we had indicated to our colleagues in the media environment, this briefing is a briefing of the social cluster. I will then allow, after we have had this input from Minister Kawazela, I will now call on Minister Zulu, Katsheni, to come forward, Dabezita, to come and speak to us. It's the opportunities. Our Tiba sanitize.
Thank you very much, Minister Mthembu, and thank you very much, Minister Mkhize, for your very elaborate report. These reports that we are presenting here are basically reports to our people. Ama-report wokuthi sikwazi ukukhuluma nabantu emakhaya, sibachazele ukuthi masikhuluma ngesivunguvunga sikhuluma ngani, sibachazele ukuthi masikhuluma bathi phecelezi ngesisuthu sifefo. I hope ke right ke sifefo ne, yeah. Harili mo re try o tlhalosa ko magaeng gore as the government wa African National Congress, government led by President Cyril Ramaphosa, we are facing the storm straight in the eye. And we don't have a choice but to face that storm. And in order for us to be able to face that storm, we have to be ready, not only as a government, we believe, but also we believe that we have to be ready for that storm as communities. And nahe as Minister of Social Development, the responsibilities tsaka ke the responsibility tsa well-being of our people, bophelo ba batho ba rona. Responsibility ya rona really Department ya Social Development together with SASSA and NDA ke gore re shebe gore batho ba rona in this environment COVID iba affecta jwang, and re tshwanetse re be na le di response tse relevant for the impact ya COVID-19. So it's for that reason gore ha ke le mo a ke tsamaye ke le mong ke tsamaya le team ya ka both ya social development le SASSA le NDA, so that if in case hona le diputso tse itseng tse ke tsebang gore maybe nka se kgone ho di araba because ke msebetso o boima o e re wetsang, so ke tlile le bona mo gore ba kgone ho nthusa to answer to some of those questions if need be. Otherwise, where I have responsibility to take, ke tla nka responsibility in what I'm going to be saying today. Minister Mkhize speaks directly to issues of societal behavior. And as a Department of Social Development, we believe that one of the biggest responsibilities that we carry is that of assisting our people to appreciate and understand, first and foremost, the challenges that we're facing under COVID-19. And therefore, I want to start where Minister Mkhize left with regard to social behavior and social behavioral change, and say that due to their proximity to communities, we are working with CSOs, CBOs, and all, so that they can play a pivotal role in assisting our communities to fight against COVID-19. When Minister Mkhize talks about the fact that we do not need to always have police to be telling us that we must wear our masks, that we must keep our distance, that we must stick to all the COVID protocols, it is because we are trying to express a strong message to our people that says, we cannot do this alone as government. This is something that needs all of us collectively as society to work on. And therefore, the areas of focus by government, and especially under our cluster, it is to make sure that the public health infection containment is something that we work together to make sure that it is contained. And I will not take that space to talk about that because Minister Mkhize went into detail about that. I think the other ministers of the social cluster will still come and talk to the public and talk to everyone around the issues of enforcement and security. I raise this issue of enforcement and security because our department is one that is confronted on day-to-day basis. The Department of Social Development, the Department of Health, and the police, and all security clusters are faced on day-to-day basis by this other scourge. The President talks about this scourge, but he also talks about the other scourge of violence against women and children. It is for that reason that we believe as a Department of Social Development that we need to have programs that will respond house to house, street to street, community to community, so that people who are at the ears and the eyes of their own communities can really join in what Minister Mkhize spoke to, the COVID forums which have been formed in many of our communities. And as a Department of Social Development working with the National Development Agency, we have also moved to ensuring that we have volunteers who can be of great assistance, and we know that these volunteers are also exposing themselves because the volunteers have to go out to our communities. And these volunteers are the volunteers, for instance, that we work with together with SASSA when it comes to ensuring that during the paydays or the days that people have to go and get their social grants, we have our volunteers out there assisting in terms of ensuring that people are wearing the masks, people are keeping the distance, and people are policing each other. I do want to take this opportunity to actually thank those volunteers because many of them are just young people in communities who want to make a difference to their communities. And while I'm talking about the volunteers, we also have community workers, we also have social workers. What we want to do as a Department of Social Development is to work with everyone and bring everyone together so that when the President talks to us about ensuring that we work according to the district development model, we do have people at that level who are appreciating and knowing what needs to be done. It is for that reason that, Minister Mkhize, we think that our working together and mobilizing these community workers and bringing them together at a district level is when they can be able to respond immediately to the challenges that people are facing. And besides, those volunteers, those community workers, those COVID forums are the forums that we can respond to and relate with because they live within the communities and they work with the communities. So the role of the Department of Social Development in particular, working together with the Intersectoral Ministerial Advisory Committee that myself and Minister Mkhize have established, is for us to reach out not only to the communities, but also to reach out to behavioral scientists and practitioners, as well as academics and researchers in the humanities and social sciences for their contribution towards establishing the socially sustainable solutions to the challenges that accompany COVID-19. So it is, while we are putting together the plans and being in a rush to do so because we need to respond as quickly as we possibly can, I always say to the people in my office, we have to be agile. We have to respond as quickly as we possibly can because the storm is here and there isn't time. So I'm making this reference to this issue of behavioral change because to a very large extent, as a Department of Social Development, we believe that we need to be able to mobilize our communities to communicate with people in such a way that they absorb the communication, the information that we are giving them. It's got to be information that is empowering to them. It should not be information that goes above their heads, because if the communication and the information that we put together, Minister Mthembu, if it is information that they can take, then you would have less reasons why you have to have the police being the one telling people that they have to wear the mask, keep the distance and all that. So it's a plea from us as a Department of Social Development, particularly because the kind of people that we are servicing, who are servicing, and the kind of programs that we have as a department, as SASSA, as NDA, those are programs that are responding to the challenges of the most vulnerable. Those are challenges that are responding, those are programs that have to respond to them. We deal with the homeless, we deal with the homes of the elderly, we deal with a whole range of other services that are done by social development, and therefore our plea is to say to the nation, we cannot do this alone. We can only do this together. And I think the President has said enough of that. So it is just a plea from our side. I think that also being a Minister of Social Development, we are looking at the storm in the eye that is COVID-19, but we have another storm, and that is the storm of hunger and poverty and unemployment. And therefore, as a Department of Social Development, working with all other departments, because it's got to be understood and it's got to be very clear that while we are responsible for social development and while we are responsible for the well-being of South Africans, we are very much dependent on what health does, we are dependent on what education does, we are dependent on what even economic cluster does, because the freedom of our people so that they can be able to take care of themselves entirely depends on the growth of the economy of South Africa so that the jobs can be created. And we raise this issue to our people at home to also say to them, siyanizwa, siyanibona, okumqoka kithi si-Department of Social Development ukuthi kulesi sivunguvungu esisibhekile manje sicela nani emakhaya ukuthi nikwazi ukuthi nibone la nihleli khona ukuthi ningazinceda kanjani. Indlala into ebuhlungu kuwo wonke umuntu. Indlala into eyenza ukuthi sometimes abantu benze izinto ezingalunganga ngoba bethi bezenza ngoba belambile. Isicelo nje kithi as i-Department of Social Development ukuthi masibambisane. So, i-National Development Agency mayivela ngasemakhaya ithi sizobheka ukuthi somashishini abancane nama-cooperatives akhona singawanceda kanjani ukuze azimele ngeenyawo zawo, senzela ukuthi nani bantu basemakhaya kungabi ukuthi ngaso sonke isikhathi nibheke uhulumente. Uhulumente kufanele ayenze into okufuneka ayenze uhulumente, kodwa nani siyanicela ngasemakhaya ukuthi ke nizame ukubheka ukuthi yini eningaqala niyenze ebese siyafika ke thina siyancedisa la kufuneka sincedise khona. Ngifuna ukusho ke ukuthi when we talk about the storm of hunger, poverty, we talk about how can we collectively as South Africans work with each other. How can we find the food that we saw from the time that COVID-19 started, the food that we saw being distributed both by ourselves as government, but also being distributed by NPOs and other organizations. We want to thank each and every South African who found it upon themselves that when they see others having the challenges of hunger, they stood up and didn't say, it's got nothing to do with me. I don't know what's happening with my neighbor. They all stood up and said, what can we do collectively together? But in addition to that, we want to say as a department, we will take the responsibility to do what is expected of us according to our means as a department, but also the means of government in general. It is for that reason that when we talk about issues of hunger and poverty, we wish to thank the Solidarity Fund for having stepped up in assisting us as a department, even though we still have to have an engagement with Solidarity Fund because poverty and hunger is going to increase. It's actually in the increase as it is now. As a department, we have looked at the hotspots as they were expressed by Minister Zweli Mkhize. We are having our own map that looks at the hotspots in terms of hunger. We have mapped out the entire country to see where exactly the hunger is. We have taken the data and information from Stats SA. We've taken the data and information from anyone else who has the information. But more than anything else, we are connecting to the provinces. And I wish to thank the MECs of all the provinces for really working with us very well. And we are holding our hands together on this one because we know that we've got a challenge in front of us. So when it comes to the issue of hunger, we will have to step up and do much more than what we have been able to do. We now have to look at the programs that we have as a department together with SASSA and say, how do we expand them beyond their normal? Because under normal circumstances, the programs of SASSA usually and the department are those which we call social relief of distress. And in many instances, those programs are simply programs that respond to disasters like floods, like fires. This time around, it's not about the fire. It's about a disaster that is facing the entire nation. And therefore, our programs will have to respond to that. And the first thing that happened actually in response was the announcement which was made by President Cyril Ramaphosa, that is of the increase of all social grants, but also that specific social grant of 350, which we have been distributing, and I will go into the details as to how many and how many people have we processed and how many have received that. But I just thought that it was important for us to say that we understand, we appreciate the challenges of hunger. We will do everything we can working with others. In fact, as I thanked the Solidarity Fund, I do want to also mention the fact that the Solidarity Fund has yet stepped up to us to say the money that we had given you earlier on was very little money. And you'll recall that's the time that I spoke here in public Minister Mthembu, I said it was a miserable 20 million. I still repeated that it was a miserable 20 million because, quite frankly, if you look at the challenges when it comes to food distribution, hunger and all, I'm told that the Solidarity Fund is coming back and is going to have a conversation with us as to what else they can do, and they are very willing to assist us. Here is what I think is very important that needs to be understood by everybody, that when the Solidarity Fund steps up to assist us, we need to have a developmental approach and a sustainable approach to food distribution. South Africa has the food. It's a question of where is the food, how do we collect it, how do we bring it to the centers, how do we distribute it, how far do we reach with our distribution, but most importantly is about us working with the communities, because I can stand here and talk about poverty and talk about all those things. It is the people who are on the ground in Mkanduli, KwaMhlabuya Lingana, and many other places which are far-flung places where they will need us to step up and give them the support that they need. So that is just the background that I think is very important for us as a Department of Social Development, the portfolio, as we call ourselves, that henceforth we are going to be focused very much on the issue of poverty and hunger. We are going to be focused very much on the distribution. We are going to be focused very much on how we can work even with the NPOs, both big and small NPOs. How can we work better? Because the experience of the past 3 months gives us an opportunity to look at where the challenges are. Now, because we are at this point in time of the briefing and we're talking about the recent announcements and the recent regulations that were made and announced by Minister of COGTA, Minister Nkosazana Dlamini Zuma, as they did in the morning in their press briefing, I'm just going to then speak to some of the critical issues that you might want to know of, also critical issues that we believe our communities need to know more about. The first one I would like to say is that we gazetted directions regarding the phased reopening of early childhood development ECD centers and partial care facilities. Sithi-ke sesiwudlulisile umthetho wokuvulwa kwama-ECD center nama-partial care facilities. Prior to the publication of directives, the department has issued a call for the sector to participate in self-assessment exercise, which is critical in determining the state of readiness to safely reopen amid the COVID-19 pandemic. Obviously, the responsibility here is heavy on us and we have to carry that responsibility, but the responsibility is much more heavier to those who run the ECDs, is even much more heavier to the parents. And again, our plea and our call is to say to all those that are adults that know what needs to be done, who have to take care of the children, it is your responsibility to also follow protocol as is, look at the directions, read the directions, understand them. From the outset, let me reiterate our position on this matter. We take our responsibility to manage and coordinate this sector, which nurtures the future leaders of this country, very seriously. Our position is that we must first determine the percentage of ECDs and partial care facilities that are in a position to safely reopen, because the sector is incredibly large and diverse. In addition to serving as an important element of our child care protection system, especially for working families with young children, the child care sector also represents an important employment sector for women, and in particular, and women in poor communities. We know just how critical this sector is, and contrary to the narrative that has gained media traction, we are not opposed to reopening. I will repeat it again. We are not opposed to reopening. Those ECD centers, they must open. Rather, the steps we have taken to date is to ensure that when the sector reopens, parents, caregivers do not have to worry about the health and safety of their children. For this reason, the directions include the health and safety guidelines, daily health screening, the use of personal protective equipment, physical distancing, and more frequent and rigorous cleaning. As of yesterday, over 9,881 ECDs have completed the online assessment. Additionally, 8,751 completed the assessment manually, this bringing the total number of ECD centers and programs that we have done self-assessment to 18,632. Of this number, 5,613 indicated that they can comply and ready for reopening, while 6,030 centers will require support to operate under the current directions. Of the 9,881 centers that completed the assessment, 1,481 were verified by the department and meet the compliance requirements. The implementation of the measures outlined in the directions will not happen overnight. We are in a storm. We are in a situation that we did not even think we would find ourselves in. We've had to be very quick. We've had to be very fast and do the best that we can to make sure that our people are protected. And that is why we want to take every necessary measure to ensure that children and staff are safe. We plan to expedite the verification process to avoid any further delays. We welcome the initiative of NEDLEC to partner with us in this regard. And in this point in time, I do want to say that partnership is of importance to us. We do also have private sector companies who have also stepping up and saying, where can we be of help? And many of them, in any case, have been supporting us even before COVID with regard to ECD centers. I must also indicate that the department continues to provide subsidy to ECD centers during the state of national disaster. In addition, we have waived the requirements for programs that already receive subsidy to submit new applications for funding for 2020-21 for the current financial year while the national state of disaster is in place. The collective amount being paid annually towards this funding is 3.1 billion, targeting early childhood development programs in poor communities in particular. So every year we spend, as a government, 3.1 billion in support of our communities. With regard to the rollout of Vangasali campaign, we have to date reached 26,000 unregistered ECD centers and programs. This is important in ensuring that unregistered centers and programs receive the necessary support to comply with the provisions of the Children's Act. And I'm raising this issue also because I know that there is talk outside which is saying that why are we having this Vangasali program of registration at the same time when we are dealing with the reopening. We have to do that because I think there isn't one parent outside who would like to take their children under normal circumstances, who would like to take their children to a center that is unregistered, because if anything happens to the child at that center, it becomes a problem. So we are pleading with people out there who are running centers that are unregistered. Please register your centers because it becomes our responsibility to support you. And especially at this time of COVID, when we want to make sure that everybody does right by the protocols. Allow me also to update the nation on the administration and payment of the Social Special COVID-19 Social Relief of Distress Grant. And I know that this is one of the biggest talk in town, and I understand so why, because people are in a very difficult situation. To date, we have received 7.5 million applications through the various electronic application platforms, which include USSD, website, WhatsApp, and email. And I think we've repeated this story over and over again. Everybody at home, wonke umuntu uyazi nje ukuthi ama application ahamba kanjani. ngicela nokusho futhi ukuthi le mali le ye social relief of distress sikhumbule ukuthi upresident wathi kufuneka ibhadalwe from July until October. Abanye ke abantu bathathe isikhathi kuyiapplyela, abanye ke bayiapplyele and laba bayiapplyela siyakwazi ukusho namhlanje ukuthi bangakhi aba-applyela, bangakhi abasebayitholile imali yabo. Of this number, a total of 4,424,720 have been approved. A total of 2,174,046. These are applications that were found to be active on various databases, including those who are currently receiving social grants, those receiving UIF benefits, or are appearing on the active database of the UIF contributors, those who are receiving NSFAS stipends, those who are found on government and employees database, PESAL and PESOL. We acknowledge the public frustration with regard to the administration and payments of this grant. However, let me hasten to add that the system is dependent on verification of applicants' information by other stakeholders to reduce the margin of error and paying ineligible applicants. Given the limited financial resources available, we have to ensure that the money does reach only those who qualify for this support. And I do want to indicate, as I've said it over and over again, also with the media, that when I saw for the first time the number of applicants who were rejected by the system, I got worried about it and requested SASSA to re-look into it, just to make sure that we're not putting other people in a difficult situation when actually they did not have anything. In line with our commitment that we will pay successful applications from May 2020, I can confirm that 3,429,808 of the approved applications were paid as at 12 July 2020. We so far have disbursed 1,200,432,800 rand. These payments are all for applicants who applied in May 2020. So SASSA will on a monthly basis reassess all applications to ensure that where circumstances have changed and income is received from any other source, the grant will not continue. I do want ukuthi abantu basemakhaya bangathuki mabeyizwa le ndaba yokuthi sizohlala siri-assessa, because kuyafuneka ukuthi simeke sure ukuthi sibhadala imali kubantu okufuneka babhadalwe, ngoba abanye abantu bayaphindela emsebenzini uthola ukuthi sesibathola back kwi-SARS database, esibathola kwamanye ama-database. Kodwa ke asizuyisebenzisa lento engiyishoyo as a way of excluding people. Ngeke siba exclude abantu if umuntu angasebenzi applyile processiwe kutholakala ukuthi imali yakhe okufuneka ukuthi ayithole uzoyithola. The reassessment of applications has already commenced and the applicants are being reassessed. We are currently experiencing the following challenges in relation to the speedy administration and payments of the social grants. Sengifuna ukusho nje ukuthi into eyenza ukuthi kwesinye isikhathi singakwazi ukukhipha imali as fast as we possibly can. Kungalento ezilandelayo engizosifunda masisha nje. Slow processing of the special grant 19 SRD grant. The initial delays have been largely due to a number of reasons, including system development. The system we are using has been custom developed for this grant. Ngoba abanye abantu beloku bebuza bathi kuza kanjani ukuthi niyawabhadala ama-grants amanye, niwakhulisile amanye ama-social grant, azange nibe nengxaki enkulu lapha, azange nihlupheke, kodwa manje seniyehluleka ukuthi nenze the same. Sifuna ukuchaza ukuthi le 350 kuye kwafuneka ukuthi siyenzele i-system yayo yodwa on the side, because yona iqale ngoMay iyaphela ngo-October. Ama-bank account kwesinye isikhathi sithola ukuthi bank accounts verification nayo ibe iyasihlupha nje kakhulu, kodwa siyafuna ukusho ukuthi manje sesisebenzile kakhulu together with i-National Treasury ukuthi isincedise lapho. Nje into ibisikhalisa kakhulu kube kuukuthi amabhange makufuneka sibacele ukuthi sikwazi ukuprocessa le mali, nabo bafuna ukuthatha eyabo imali, and thina sibona ukuthi asikwazi ukuthi abantu sibanikeze u350 ebese sithi kulo 350 u50 rand ufuneka uthathwe ubank or u10 rand ufuneka uthathwe ibank. Sizame ukuthi abantu bayithole yonke le mali yabo njengoba injalo u350. Okunye ke futhi isasa yacela iposi to open accounts for clients to enable payments without delay. Clients will be able to update their banking details and reference in future should they wish to use this different bank account or even the cash send option and not continue receiving the money through the post office. Siyabonga nje ukuthi iposi impela isincedile kakhulu la ngoba iposi iye wavula ama-accounts abantu automatically, so abantu bakwazile ukuyithola imali yabo. Kodwa ke sisakhulumisana futhi no uMinister Stella Ndabeni-Abrahams ukuthi ke sibone ukuthi lezi zinto esizibonayo kwamanye amaposi lapho khona amaposi uthola ukuthi izigebengu ziyafika zizofuna imali yesasa, singenza kanjani ukuze iphele leyo nto leyo. High number of declined applications, sengichazile lapho ukuthi senze njani, sengibacela nabakwasasa ukuthi ngiyacela ukuthi impela nje ama-application wabantu lawa abazange baphumelele mababuyele baphinde babheke futhi ukuthi yini into esingayenza ngoba u3 million wabantu abangatholanga imali who were declined was just too big. In order to address further exclusion errors, SASSA is implementing a resource mechanism for applicants who have been declined and wish to review the decisions. Applicants can now direct their appeals for review ngoba ke sinendlela ezimbili zama-appeal, indlela ye-department nendlela ye-SASSA. Indlela ye-SASSA yona yama-appeals, i-email address yakhona iti COVID-19 srd@sassa.gov.za. I think nayo le sesiyikhiphile impela nje abantu abaningi bayayazi ngoba ngisho namhlanje ngoba sila sikhuluma neintatheli ngethemba ukuthi nabo bazosinceda ukuthi bayidlulise le email address. This facility will have dedicated staff to respond timelessly to all emails. We would like to point out that applicants requesting recourse need to upload documents. The recourse process will be electronic. Nanzo futhi enye indaba esisayidingida ngoba phela u-electronic uyasebenza kwabanye abantu, u-electronic akasebenzi kwabanye abantu. So sisabheka ukuthi nje njengoba sasincedekile kuqala sisebenzisa ama-volunteer we-NDA, singenza kanjani ukuthi namanje sibe nama-volunteer amaningi impela angakwazi ukunceda. Work is currently underway to develop a recourse mechanism which will attend to the complaints and disputes raised while not extending the lifespan of this intervention. In addition, any recourse mechanism will have to be electronic in order to cope with the numbers involved. Manual processes are not viable options. And of course, we would like to also say the manual processes are not viable for us because most of our offices are opening and closing. Some are having less numbers in the offices because unfortunately for us, we are also as civil servants, as ministers, as everyone, we are also affected. And ISASA, in fact, at this point in time, is the one that has the highest number of deaths and the highest number of COVID-affected members of staff. SASSA has got the largest number, and we're doing everything we can. And again, those numbers, Minister Mkhize, the numbers are following exactly what you see as hotspots. Your usual provinces of the Eastern Cape, Western Cape, and Gauteng. We've lost more people from a SASSA point of view in the Eastern Cape more than any other place. The other issue that is very important now is the management of disability grants. Since the declaration of the state of the national disaster, I have been inundated with concerns about the limited access for grant applications by persons with disability. SASSA has implemented a strategy to progressively reintroduce these services in accordance with the available resources, taking into account that access to health facilities remain a challenge. SASSA has contracted 465 doctors in all the provinces who are assisting with the assessment. Priority is being given to those who were assessed prior to lockdown but did not complete the administrative process, as well as those who were booked for assessment which could not take place during level 4 and 5 of lockdown. New applicants will be assisted at SASSA offices on an appointment basis and subject to availability of resources to complete medical assessments, which are legislated requisites to an application for a disability or care grant. I do want to say here, ko magaeng gore ke a tseba gore batho ba bangata ba ne ba kgona ho ya ko dingakeng tsa SASSA ne ba kgona ho ya because there were no restrictions, and gona no re na le problem ya di restrictions. More than anything else, even the doctors themselves bana le di challenges tsa hore where are they going to do the assessment, because in the past they would do the assessment ko di clinicing, ko di petlele, and right now Minister Mkhize needs all the space for the patients. So the last thing that the hospitals will want or the clinics will want will be people who are coming to assess. So I have given the direction to SASSA to say, let us look for other options that can help us so that people are not lost in the system. You cannot lose people who need the assistance of government. The fact that there is COVID doesn't mean that these people now have food, now have other things in their homes. So as SASSA and the department, we really need to look for other ways of ensuring that we engage with the doctors in particular. In fact, I've had a few calls from some of the doctors who were saying, Minister, we were doing a lot of good work here. We were splitting our work as in our private clinics, but also taking time to give attention to SASSA and those that are wanting to be assisted. And now, because of COVID, we are unable to do that. So as a department, we need to find solutions to problems like that. We have updated the directions relating to special COVID-19 SRD grant to include payments to the grant to holders of special permits under the Special Angolan Dispensation, the Lesotho Exemption Permit Dispensation, and Zimbabwe Exemption Permit Dispensation, and asylum seekers whose Section 22 permits or visas are valid or were valid on the 15th of March. And again, we will recall that there was a court case that we had to contend with, and as a department, obviously, we needed to look at what leg do we have to stand on, whether constitutionally or according to the Act. And we now have this situation, and SASSA is currently working on what needs to be done to make sure that that is implemented. The amended directions informed by the North High Court judgment were gazetted on the 2nd of July 2020. It will cost approximately 689 million to implement this judgment. We are currently in engagement with the Department of Home Affairs to verify the authenticity of all permits to limit fraudulent applications. This is the time, actually, I was saying to the department, this is the time also which we can use to fix our data this way or the other. COVID has happened, it's a painful process, but this is also a time for us to fix our data. And we've learned lessons from the SRD 350 that we're paying to our own people, because many people were supposed not to apply, they dared apply. They applied even though they knew they're not supposed to apply. It is important to note that, like all other applicants, the asylum seekers and special permit holders will also be subjected to eligibility criteria. In addition, SASSA has engaged the United Nations High Commission on Refugees to obtain information on refugees and asylum seekers, as well as an organization working with these communities to ensure that information on the grant and application channels is available for all those who seek to apply. Again, we have to work together here. Still on the subject of the social grant, I would like to mention that discussions for the introduction of the basic income grant have been brought back to the table. The basic income grant is being considered in view of SASSA's legislated mandate as well as the primary mandate of the National Development Agency. In relation to the basic income grant, the NDA's primary mandate of eradication of poverty and its causes by granting funds to civil society organizations for purposes of A, carrying out projects or programs aimed at meeting development needs of poor communities, and B, strengthening the institutional capacity of other civil society organizations involved in direct services provision for the poor. SASSA has a comparatively well-developed infrastructure that reaches far more, 31.2%, than any other agency. Therefore, the basic income grant will result in most of the poorer individuals continuing to access the COVID-19 SRD social grant benefits. Obviously, the basic income grant will simply cover an ease of grant administration, granted that our current social security grant system does not permit universal coverage. The current proposal will help realize the government's broader social security reform. The basic income grant will be unconditional, individually targeted at all the levels that will lift individual South Africans out of poverty. The discussion about the basic income grant has been going on for a very long time. And we still have to, though, it's not something that we're going to implement tomorrow. There's quite a number of things that we have to do and systems that we have to put in place to make sure that it covers the correct people. Since we already have category grants for children, older persons, and persons with disability, the basic income grant will be an income support grant for the population aged between 18 and 59, and these are the people who are always finding themselves falling in the cracks. We fully welcome the President's pronouncement on the immediate reinstatement on the ban of the sale of alcohol, and urgently instructs the relevant departments of government and the Department of Social Development being among this, to mobilize and coordinate their resources and promote programs towards invoking aspects of the National Drug Master Plan, as well as the Gender-Based Violence and Femicide Master Plan. We're putting this here because as a Department of Social Development, the issues of gender-based violence is something that we have to work on we work with on day-to-day basis. Therefore, the Department of Social Development will urgently invoke its programmatic response as part of the government's wide response that is planned and deployed through provinces, net joints, interministerial committees, and so forth. Noting that invoking the COVID-19 responsive measures will immediately ensure, amongst others, the deepening of efforts to protect women during this period, particularly noting the curfew that is applicable between 21 hours and 4 hours in the morning. Program level linking of these will be forthcoming. As it has been demonstrated, the ban on the sale of alcohol will contribute towards freeing up the much needed medical capabilities which Minister Mkhize has spoken to. We cannot emphasize the need to partner with civil society organization, community-based organization, faith-based organization in realizing compliance with the President's pronouncement, regulations and departments and directions. We call upon our people to work with us to make sure that we fight against gender-based violence. We have increased the capacity of the GBV Command Center through recruitment of social work interns from the Health and Welfare SETA and NEDLEC to support and intensify services rendered. The officials will be deployed to the provincial departments, the National DSD Office, and Gender-Based Violence Center. We have also recruited an additional 1,809 social workers on a 6-month contract to assist with the provision of psychosocial care and support to vulnerable groups and families. Ne ke batla go bolela gore taba ya di social workers remains taba e bohlokwa for all of us, because ka mokgwa re bonang ka teng as a department, re nagana gore if communities and street by street and everywhere would have more social workers, re ka kgona gore re reduce the other social ills that are a problem. And ha re batle hape gore when we are busy dealing with the issues of COVID-19, really bad, as a Department of Social Development, we've got other services that we are doing, and we put those in the front because while we're busy fighting COVID, there is that other fight for us as a department that is gender-based violence, all other social ills, poverty, unemployment, and inequality is part of what we have to work on, working together as a government. Ngiyabonga Mthembu, ngicela ukusho ukuthi okubhlungu esinako namhlanje ukuthi silahlekelwa abantu abaningi. Njengoba namhlanje sizwile nokuthi sesilahlekelwe nawo omunye womphakathi wethu, umuntu esasizabalaza naye, umuntu esasigijima naye, umuntu ebesingacabanga nokucabanga ukuthi singathi sivuka ekseni sizwe ukuthiwa hayi uZinzi Mandela usesishiyile. Kulokho sicela ukubonga kuwo wonke amafamily la ekhona. Sicela ukubonga ukuthi amafamily ayazama ngayo yonke indlela ukuthi azivikele. Sicela ukuthi amafamily njengoba si Ministry of Social Development, we are about the well-being of our people. I-call esisho ukuthi okokuqala njengoba uMkhize eseshilo wathi ubonga ama-health workers nodokotela nabo bonke, nathi siyababonga, kodwa ikakhulukazi thina sicela ukubonga labo emphakathini ababonisayo ukuthi bayayi-understanda lento. Sicela ukuthi inkulumo ethi hayi mina angiyazi ukuthi COVID yini, mina ngakayiboni ukuthi COVID ibulele bani, ngicela ukuthi wonke umuntu azi ukuthi i-COVID iyabulala futhi ayikhethi. Ngakho ke wearing of your mask, keeping your distance, sanitizing, and doing all the right things is important for us. Nathi suhulumende, on the other hand, re tla etsa everything in our power to make sure that we help our communities. Thank you.
Thank you very much to Sis Malindi. Siyabonga, Sis. We are now at that stage where we will then take questions from our journalists on the inputs made by our ministers. Now, as you can see in this facility, we don't have a phone-in capacity, so we will be taking the questions as they have been directed through our WhatsApp system to Nongqeba. Do we have any questions?
Yes, Minister.
Oh, okay. Thank you very much. Let's hear from you, Sis Nongqeba.
Thank you, Minister. The first two are the two questions from the earlier briefing that we said we will leave for this briefing. The one was from Vickers Berger from Netwerk 24, and the question was, it's addressed to the Minister of Health. Apparently, field hospitals across the country, especially in Gauteng, are not equipped with the necessary equipment like ventilators. It is alleged that these field hospitals are in effect wards with beds, but can't operate as a hospital. Is this true? Please provide the necessary details. The next question, in fact, most questions are directed to the Minister of Health, is from Anton from Pretoria FM. It's also from earlier today. President Ramaphosa last night said there's now clear evidence that the resumption of alcohol sales has resulted in substantial pressure being put on hospitals. Please share those numbers with us. How many trauma cases how many trauma cases have we had that were alcohol related that have been recorded since the resumption of the sale of alcohol? And a related question to that one is from Charlotte at EWN. She's asking, are you able to expand on the modeling done with regards to the effects of alcohol in the health system? Are you able to say how many more COVID patients the system will be able to handle as a result of the reinstated ban? The next question is from Monique from Bloomberg.
Can you repeat that question that you have just concluded now?
Okay. The question is, it's from Charlotte at EWN. Are you able to expand on the modeling done with regards to the effects that alcohol has on the health system? Are you able to say how many more COVID patients the system will be able to handle as a result of the reinstituted ban?
Okay, let's continue.
The next one is from Monique from Bloomberg. She's asking, why has Gauteng been lagging other provinces and the national rate in terms of recoveries? This was the case even before Gauteng became the epicenter of the virus.
Gauteng lagging on recoveries.
Yes. So basically the question is, why are people who get infected with the virus in Gauteng taking longer to recover as opposed to other parts of the country? Tamar Khan from the Business Day is asking, why have the Ministerial Advisory Committee advisories to the Minister not been made public, and what would it take for them to be published now? And what was the MAC advice to the Minister on A, taxis and public transport, and B, alcohol?
So basically there are three questions. That the first one is that they don't know who's advising the minister.
No. The question is, why has the advisories from the MAC not been made public?
Oh.
And what would it take to make them public?
Okay.
And what was the advice from the MAC on the issue of transport and alcohol?
Oh. Okay. I think let's take these five for now. Kabazela, the media requested that it would be good if we speak from here, if we respond from here. All of them are directed to you. So that Azozago Kabazela.
Thank you very much. It will not be possible to give all the figures, as some of them need us to open up a bit of references if it's asked the way it's been asked. So we will try and answer as much as is possible. The first issue is the issue around the Gauteng hospitals. What has been asked is what is happening in terms of the hospital beds not being equipped. Field hospitals in the whole country have been established in a particular way, where they were basically a type of hospital beds where we created space, and then they were put, one next to the other in large number because they were meant to accommodate a large number of patients who are coming in. And so they've got minimal equipment, which is basically for monitoring those particular patients. But with time, increasingly, it became necessary to look at the additional fittings that needed to be put in, and that is in terms of the oxygen. And so a lot of them now we are refitting with oxygen, even in areas where we had not initially intended to put oxygen, because of the increasing evidence to indicate the need for early administration of oxygen. So whether you would go to the Western Cape, Eastern Cape, Gauteng, KwaZulu-Natal, you'll find that that's the pattern. I explained the issue earlier, and I indicated that not only are we putting in the additional fittings for oxygen, but we have also started putting in, bringing in oxygen concentrates, tankers of oxygen concentrates, so that we can, in the meantime, whilst we're waiting for the fitting, would be in a position to utilize those beds in a manner. At the beginning, we used to even have a situation where if someone was positive but even didn't have had recovered, didn't have symptoms, would keep them in some of the field hospital beds so that they can stay there until they are over the infectious period, that they can go home thereafter. So the upgrade is something that is going on as we are talking now. The next issue relates to alcohol. I'd love to share, if there was a slide presentation, I would love to share this to the colleagues, because we had this sentinel trauma report, which was actually done in Tygerberg, and also looking at experiences from other hospitals. And that this data showed clearly that the lockdown regulations and alcohol ban reduced the number of trauma presentation to the order of 40 to 50%. And so they gave us a number of centers which were looked at. So, for example, the one of those, let me say, some of those areas involved, like George Regional Hospital, Mitchell's Plain District Hospitals, Groote Schuur Hospital, Heidelberg Hospital, Tygerberg Hospital, and we've got graphs that were showing the reduction that happened in those particular areas. So this was actually specifically reported, and so the reports came up here indicating that there was a reduction which for the 2 months of the lockdown, and as soon as the lockdown was eased, and then of course the numbers started increasing in all those centers. And so prior to the lockdown, they indicated that there was a consistent trend of weekend spikes of 140 to 260 trauma cases across those 5 facilities which were sampled. The average median across that period was 89 daily trauma cases. And those numbers, for example, in the George Regional Hospital, before the lockdown, they had 3,905 patients, and then after the lockdown, during the lockdown, it was 1,644. So there was a huge reduction at that level. And in Mitchell's Plain, the figure dropped from 3,895 to 1,480. In Mitchell's Plain, the figure dropped from 3,485 to 1,462. In Heidelberg, it was 1,529, and the figure went down to 611. And in Tygerberg, it moved from 226, and it came down to 80. So I can make this available because this is information that is available. These were indicating these numbers we've got even more details if someone could actually be in a position to look at the slides that we've got. So during the lockdown and the alcohol ban, this reduced to approximately 60 to 80 trauma cases at the weekend spikes, and the average across the period reduced to 46 daily trauma cases. So this was done by the people who actually manage, study, and monitor trauma. They looked at it from that point of view. 1 month prior to the release of the alcohol ban, the average median over that period was 50 daily trauma cases. And so the numbers went further down, and of course, after the trauma that actually gone up. So the numbers had gone down, as I indicated, the Mitchell's Plain District Hospital went down to 548, and George Regional Hospital to 478, Grooteskier 435, Heideveld 155, Tygerberg down to 22. And so the numbers of patients who were admitted 1 month, okay, let's say 1 month prior to level 3, they had 669 admissions, and 1 month after level 3, that figure went up to 1,032. So it went up by 42%. And then those who were discharged prior to level 3, prior to 1 month prior to level 3, they discharged 879 patients, but 1 month after level 3, they discharged 1,183. And then on the ICU, the daily average trauma cases requiring ICU care admission, pre and post admission of alcohol ban, they moved from average daily numbers, moved from 2.7 per ICU or high care admission to about 9.5, and that was the level. So after lifting the alcohol ban, the number of trauma patients requiring ICU or high care admission at those tertiary hospitals in the Western Cape increased from a daily average of 2.7 to a daily average of 9.5 admissions, which was a 350% increase in trauma patients requiring ICU and high care admission. And this is a similar pattern in terms of the impact on death from road accidents, and also this was also showing the numbers of people who had died of injury, if you had compared at that point with what happened in the 2016. Out of the people who had died there, 80% of all injury deaths occurred in males, and 60% of them were between 60 and 39 years of age. And in the process, if you broke them down, 50% were homicide victims, and 60% were pedestrian fatalities, and 47 motor vehicle accidents, 65% fire fatalities, 47% drowning. All of those who were tested, those percentages were actually positive for alcohol when they were tested. Then of those who had died, 50% were homicide, and then 23% were transport, suicide 11%, and other accidents were 15%. So those are the kind of figures that we're talking about. This is open information and it can be shared, but since they ask direct question, we make this available to those who might be able to receive this, these numbers. This covers both the questions that we raised about alcohol and the modeling of what we used to look at what might happen in case of the alcohol ban. It was actually very specific to say what happened before, what happened during, what happened after. And that we had been able to deal with. The issue around Gauteng that's being raised about why is the Gauteng lagging behind? It's the rate of increase of the infections. The bulk of the people who have been tested positive in Gauteng were tested in the past few weeks. That means that there were more people who were tested positive in 2 weeks than would have been those who were tested a month earlier. So that means, therefore, on the average on the average recovery period, those who recovered will be fewer than the number that has been infected, simply because the month earlier we had fewer people and the month later we had more people. So you can make an estimation that beginning of June, the numbers that Gauteng had would probably have been about, if I may just recall offhand, would have been about 40,000, say 4,000, but a month later the number had gone up almost to 40,000. So in that period, you've got too many who are fresh infections, therefore they can't have recovered, and it takes a while. Whereas in the Western Cape, there would have been 20,000 at the same time, and then when they grow up to 40,000, the numbers are not quite equal. So the difference between the two is the new infections are rising faster than the older ones, and that's what creates the difference. So on all the numbers that we have got now, the majority of the people who have been infected would have come up in the past month, and therefore they are much more than who we had earlier, and therefore the gap in recovery is affected by that. Well, the question that was raised by Tamar Khan about the advice from the Ministerial Advisory Committee. It's a very interesting coincidence that that question comes up, because it's a debate that has been held by the members of the Ministerial Advisory Committee. And there has been a very interesting discussion among some of them, because some of the members have been wanting to, if we ask for an advice, they have been debating as to whether they should be publishing those advices. Now, it's a very unusual advisory committee that would publish an advice meant for its own department and then publish it before it's even been processed, before it's been discussed, because as a principle, an advice is a guidance so that you handle issues taking into account various issues that are pertinent to the issue. But it is a number of advisors that will end up having to consider when we take the matters. In some instances, you take the advice and subject it to a consultative process, and that consultative process, in the process of implementation, will force you to vary certain things. Now, the question here is that there have been some members who have been under the impression that if they have issued an advice, therefore they need to be the one who must go and publicize it in public, and they might be the ones who must go and that it must be immediately be implemented, not taking into account the fact that there's a whole lot of processing that is involved in the administration of dealing with a complex matter such as this one. So, for example, there was an instance where there was quite a debate about the advice in terms of how to handle the specimen that have lasted much longer than the time they the test was expected. So some of the members had actually said they must be discarded and we must send SMSs to the members of the public to tell them that their specimen has been discarded. And then we moved on to get another advice, which was now a legal advice. And it turned out that, in fact, we could have been liable to a serious criticism from a court if anybody took those issues up. In other words, it is not possible to take an advice and then publish it before it has been processed. The policy-making decision in health is a National Health Council. That's by law who needs to issue policy on health. The various institutions, the research bodies, the advisory committees, the Minister of Health has got a number of advisory committees. There are advisory committees on the mortality on maternal mortality, the advisory committees on the management of cancers, the advisory committees on antibiotics resistance, the advisory committees on a whole lot of matters. You could imagine if you were to each one of them go public, then they will go out into the public even before the body that's been charged by law to guide and health policy matters, which is the National Health Council, that consists of the ministers, the heads of departments, the various management structures within the departments and the various provincial MECs, that all of that gets to be published as though it is already policy when in fact it has not been processed properly. That is the reason why it would not be possible to publish every one committee, advisory from a committee. But also, the committee is not like the committee is always unanimous. Sometimes the committee is itself not unanimous, and what happens is that they will take certain issues and have different views. And of course, that still comes as an advice, an advisory to the, to the ministry, because the ministry has to take into account all those factors as we move on with the issues. As it turns out in these matters that are mentioned here, we needed advice from various players here. And so the ultimate decision that would have to be taken would involve the input from the advisory committees on the Ministerial Advisory Committee for the Minister of Health. It would involve the work that would have been done by the Department of Transport. It would also involve consultations with various provincial leaders, MECs, and heads of departments. So what we have given here is a combination of all of that process, and that's really what ultimately what it comes to. There may be areas where there might be differences of approaches, but certainly this issue that we've released here has gone through a process where there was consultation with the Ministerial Advisory Committee, the Department of Transport, the taxi associations, and the National Command Council. All of us together have come up with what we have here. So that is what ultimately is relevant for this particular matter. In the case of alcohol, quite a lot of debate. There is a document which was tabled to us which gave pretty much the issues that we raised in this discussion. And it was reported to me that the Ministerial Advisory Committee had quite a robust debate on the matter, and ultimately many felt that they did not wish that they should be the ones who advise government on this matter. Although the reports that we've got come from the professors and the members of the Medical Research Council, and also has been used by various provinces in managing the health services. At the time, the department, the Ministerial Advisory Committee made a lot of comments and also felt that maybe they shouldn't be the ones who are asked to make a comment on this particular matter. And therefore, matter was taken forward, and then a broad process of consultation again was followed. And at the end, this information that I've tabled in terms of the numbers, in terms of the research, in terms of the authority of those researchers that actually fed into the process, as well as the issues that have come from the various managers of various institutions whose views have also been taken into account here. So sometimes, because we have said that there is a ministerial advisory committee which advises on COVID-19, it doesn't mean that that's the only body that will be giving information that will be taken into account as we take the various positions, and also that there are various other players who make contributions that ultimately formulate the policy position that we take. That would be, colleague, my response to those issues. Thank you very much.
Thank you, Minister Mkhize. Well, let's take another round of questions, if there is any.
There are many.
You, hallelujah. Okay.
Okay, Olim Gambi from ENCA is asking the Minister of Health, how credible and extensive is evidence that COVID-19 is an airborne virus? If the answer is affirmative, then why is it safe to load taxis to full capacity? A related question from Charlotte from EWN is, if 20 minutes is the safe time, for want of a better phrase, does that not render most taxi commuters unsafe? Silva Sibia from News Note Agency is also asking the Minister of Health, last night, President Ramaphosa highlighted that there is a shortage of 12,000 health workers in the country. How long did it take government to notice this, and what is being done to address this issue? Because there are nurses who are at home with no jobs while their skill is desperately in high demand. Then there are questions to the Minister of Social Development. Tumelo Zulu from SABC Channel Africa is asking, there is a lot of young people who applied for the 350 social grant relief who haven't received any response from government. Should they keep applying, or does this mean that they didn't qualify even though they haven't received an acknowledgement or rejection? And next question to the Minister of Social Development is from Lindiwe Zulu.
It's from her.
Oh, sorry.
That would be nice.
From, no.
I would like to hear that question.
It's from, sorry, it's been a long day, Minister, sorry. From Evelyn Morris from Caxton, Durban. And the question is, we have been told by child and youth care centers that they are not returning the children in their care to school. Is this a policy decision by the department? And one last question to...
Just if we can just repeat this one so that we hear what... I didn't get the essence of the question.
Okay.
Yeah, just repeat that now.
Okay. We have been told by child and youth care centers that they are not returning the children in their care to school. So children who are in the care of child and youth centers are not returning them to school. And the question is whether this is a policy decision from the department.
Okay, next.
Lizeka from News 24, also to Minister Zulu. You just spoke of hotspots identified by your department on hunger. Can you please share the hotspot areas? The department had indicated that it needs an additional 700 million rand from Treasury to meet its constitutional duties towards social relief of distress grant. Has there been a response from the National Treasury in this regard? Thank you, Minister.
Now, since Ukabazela was here, let's start with you, Mganon. Malindi. Let's start with you with your questions before Kabazela comes back. Thank you.
We have to keep trying with these masks. One day we'll be able to do it very easily. I can see you pulling yours up and down. No, thank you very much. Young people who have applied and have not received any acknowledgement or any response, I'm not exactly sure how that happens, because if you have applied, you are either informed of the fact that we've received your application, we've processed your application, you qualify or you don't qualify. So maybe I will ask the CEO of SASSA if in their system they can be able to respond to something of that nature. But of course, kuyafuneka ukuthi umuntu axolise kakhulu kulabo aba-applyayo uthole ukuthi abaphendulwanga. The normal system, as we have indicated, ukuthi abantu ba-applya kanjani. One of those, all those systems need to be able to respond back to you ukuthi i-application yakho itholiwe or ayitholakalanga. Andazi ke kuba kwenzeka ntoni uba abanye abantu ba-apply uthola uba abaphendulwa. Ngicela uba into leyo isasa engasiphendulela ngoba uCEO wesasa ukhona namhlanje nabanye abesasa bakhona. Ndazi ke uba ungavumela na Minister, kuba abantu besasa bawuphendule lo mbuzo if it's allowed. Ngiqede qala. Yeah, no, ngizoqeda and then I can ask them to respond to that. Umbuzo wesibili about child youth centers, awukho umthetho onjalo, ayikho ipolicy enjalo. Njengoba sichazile earlier on ukuthi sisebenzisana nama ECD centers, sibanikeze ama-direction okuba kufuneka basebenze kanjani ukuze bavule ama-ECD centers wabo. Ama-ECD centers ukuvulwa kwawo will depend on i-readiness yabo, and i-readiness yabo depends on abantu abawaphethe ukuba basebenza kanjani ukuze avule. Awukho umthetho or i-direction esike sayikhipha siyi-Department ye-Social Development engavumeli ukuthi abantwana baphindele. Kodwa ke ngifuna ukusho ukuthi ama-parents kuyafuneka ukuthi bakhulumisane nabantu abarana lawo ma-ECD centers ngoba kungenzeka ukuba abantu bacabanga ukuthi uhulumende othi mawangavuli, but when all is said and done abantu abawaranayo yibo okufuneka basho. Njengoba sibona nje amaningi a-private in particular, sengike ngathi ngabheka ukuthi lawa a-private ngoba esikhathini esiningi ama-parents abhadala imali eningi, akhipha imali eningi. Mbonile ukuthi i-communication impela between the private owned ECDs and the parents abaletha abantwana babo is very, very sharp. So asikaze siwukhiphe ke umthetho onjalo. Hotspots areas, I did indicate earlier on that the very hotspots that Minister Mkhize speaks about from a health perspective are almost the very same hotspots that we have as a department. But the most hotspots are in the Eastern Cape, are in the Northern Cape, are in KwaZulu-Natal and Mpumalanga. Now, there must be a difference between what we are talking about. Ama hotspots which are mentioned by eHealth are basically the hotspots in relation to COVID-19, whether it's issues of infections, whether it's issues of deaths and so. Ours, we decided in order for us to be able to have systems that would respond properly, we must look at hotspots so that when we develop our interventions, the interventions must be guided by those hotspots. But also, we decided that they must be guided for us to be able to work with through the district development model, because we see that model. In fact, that district development model for us as a department is something that the department almost started long before there was even an issue of district development, because our community-based feeding schemes and food nutrition schemes, they are based on districts. So if I think I can get the information about who asked the question so that we can send them specifically the map that we have. But generally, the hunger is hunger. Again, I say we are informed by Stats SA, we are informed by other agencies that deal with hunger coverage in South Africa. I think that's all. There was the other issue of, I think even the 700 million, the issue was whether Treasury has given us, whether Treasury has given us that amount or not. Look, let's all start from a premise that says, the budget has just been delivered not long ago. The review of the budget was delivered not long ago by the Minister of Finance. And of course, for everyone, money is never enough, but it's always a negotiation. And the bottom line is that for us, we as a department, we are saying, by the way, Minister Mkhize, now Minister Mthembu, was saying, you know, the issue of hunger, we would want to see ourselves as South Africans in general, the way we have responded to COVID because we fear COVID. I think we need to also find a way of responding to poverty and hunger almost in the same way, because I'm repeating, it's not to say that South Africa is in food shortage. You know, when you go to other countries where there's been drought and then they've not been able to plant, they've not been able to produce. South Africa produces. The biggest problem that South Africa has is inequality. The biggest problem South Africa has is unemployment. The biggest problem South Africa has is the fact that even those who have need to step up and say, just like the way they've stepped up in the beginning, they need to step up and help us with a sustainable and developmental approach to the issue of hunger. Because I've said it again in this platform, and I'm saying it again. It's not to say that those people who are poor in poor communities don't want to be better off. They want to improve their situations. They want to be better off. They just need us to help them. And those that actually do not have no food today is simply because the ones who are waking up in the morning and going and hustling one way or the other, they are unable to do so. So our plea is to the NPOs, is to the private sector, is the social solidarity fund to say, can we come together and work in a sustainable way so that we don't behave like soldiers who are given a packet of, a tin of something to eat and biscuits and something, and they are told you are going to be traveling the next 200 kilometers on your own, and they sit and they eat the food now and finish the food now. We are in a war situation that needs us to say, we don't know how long this is going to be able to going on. Can we be rational in what we do? Can we be, of course, sensitive to the needs of the people and the poverty that's there? But can we make a plan that can be able to make sure that the food that we have sustains and nobody goes hungry in South Africa, as the President said? It's possible for us to do that.
On the 350.
Sanibonani. On indaba ye 350 kulabo aba-applyile abangazange bathola i-response, akunzima ukuthola i-response mangabe asikakuphenduli. mangabe mhlamba kho SMS esiye sakuthumela yona sakutshela ukuthi approve noma awuka approve. Indlela zimbili ongazisebenzisa. Ungangena kwi WhatsApp number lesiyisebenzisayo engu 082 046 8553. Uzothi mawungena kuleyo WhatsApp uzothola ukuthi kuneyindlela ezimbili. Kunendlela yoku-apply, kunendlela ethi update my status. Uzabe uyachecka ke i-status sakho, mawucheck i-status izakutshela ukuthi application either pending or approvilwe noma decline. So indlela onga establisha ngakho. Enye indlela onga establisha ngakho ukuthi uthumele kwi HTTPS usebenzise uchecke kuleyo ndlela as a /srd.sasa.gov.za bese uyahamba ke uchecka i-status sakho izabe siyakuchazela ukuthi i-application yakho ikuphi. Ama-application wonke wango May bese siwaphendulile. Akhona nje ambadlwana awango June asekugcineni besingakawaphenduli. Kodwa wango May wonke siwaphendulile. Mangaba uyitholanga kusho ukuthi ke mhlawumbe kusho ukuthi khona la kubambe ke khona. Kodwa bonke abantu aba-apply ngo May njengoba besishilo sathi siye kwafanele ukuthi sibuyele kulabo besiba declineile. Bacishe babe ngu-1,000,000. Kwafanele ukuthi sihambe sohlolisisa njengoba uminister bekacelile ukuthi asibhekisise ngoba bebabaningi kakhulu i-response yakhona beyithi bakwi-UIF abantu ba-complain abathi cha abasebenzi. Sasesiyabuyela siyababheka seba ngu-1,000,000 ke esibese sithi masiceda ukubahlola sasesiyaba-approve sasesiyabacela ke ukuthi abaphinde either balode ama-banking details wabo noma sizobabhadala ngezinye indlela zimbili ezinye indlela esibhadala ngazo. Either sibhadala eposini masingana ama-detail ngoba sisebenzisana neposi ukuthi sivule i-account noma khona sizabe sesibabhadala ngebhange nge-e-wallet or cash send. Indlela enye yesithathu esizoyisebenzisa esiceda ukulungisa sisebenzisana namabhange ukuthi sikwazi ukubhadala ngaleyo ndlela. I think as a way of explaining anybody who has not received any response, the important thing is to either go to our website, which is https://srd.sasa.gov.za and check your status. The other way is to go to the WhatsApp line, and once you've typed the number 082 046 8553, it will give you 2 lines. On those different lines, it will give you either application or check your status. You will then check your status and you'll be able to see as to where your application is, whether it's pending, it's approved, or it's been declined. Yabonga, Minister.
Sibonge CEO Kabazela.
Thank you very much for the questions. I may have missed some of the names of who asked the question. I just caught the essence of the question. I think it should be also quite interesting what one has been observing in the past few weeks as we're going through the process of the getting advice from various experts, that quite often a number of things come out. One of them is the fact that there are many schools of thoughts that you will find, and so you will find, debates where everyone will agree. There will be other debates where there are disagreements. There are other instances where in the middle of the disagreement, we have to take the best possible way. And in the other instances, we have to deal with situations where those who had views inside the advisory committee decide that they'd like to go and discuss their views in public. We've seen a lot of that happening, and when that happens, we understand that individuals have got a way of raising their points of view in public, as it were. So when you go through the approach to the advisories, you have to take into account the situation that nothing is 100% and nothing works perfectly like in a laboratory. You have to bring the issue of what is your best approach to trying to solve the issue. So the cause of infections insofar as the coronavirus situation, the general view has been that it spread through mainly 3 modes of transmission. One is the direct contact with infected droplets. The other one is contaminated surfaces. The other one is airborne transmission through the floating of droplets, which are less than 5 micrograms, microliters, that remain airborne for long periods. And then the extent of airborne transmission remain resolved. This issue arose from the debate of the committee to say they have noted that there is the issue of the airborne transmission that's being raised as a very strong possibility, that matter is still being discussed, it's not necessarily resolved. But whether you look at it as droplet or airborne transmission, insofar as the spread of the infection, the risk exists even before those questions are closed or whether they are finalized. So the risk does exist, whether we look at it from airborne or whether we look at it through droplet transmission. So that issue means, therefore, that we have to do something with the transport because of the fact that people there tend to be congested. But that means that if people went into the taxis without masks, the risk would be much higher. If they didn't sanitize their hands, the risk would be much higher. And there are lots of issues that have been debated. For example, possibilities of putting in partitions between the seats. That was discussed, and there were various views, and that ultimately got thrown out. Then at some point there was a discussion of giving everybody visors to protect them from such infection. Over a period, it was felt that was not going to be necessarily making a lot of difference. And the concerns were also about that, the drivers of the taxis would be exposed to so much of infection, with everyone breathing behind them and being there the whole day and so on. What do you do to put up partitions and so on? So there was a lot of discussion that have gone into this particular matter, as it were. So when we ultimately come to a conclusion, we then take the best that is possible. In the experiences of other countries, there actually were talks of reducing the numbers from not even 70% to 50%, and they were looking at examples in various countries of how they were trying to manage this situation. Obviously, we also had to go into the issues of what the taxis objectively need to be considered in terms of ensuring that they can continue to run as the transport that is needed for a number of for people coming from all over in different towns, townships, suburbs, and so on. And it became very clear as well that there's a cutoff point beyond which it will not be possible for the taxis to run. And that was the work that was done by the Department of Transport. So all of these factors were taken into account, and therefore, as I said, the decision on ultimately the best combination of features that would help us to be able to reduce the risk of infection, that came from a lot of those issues. So the 20 minutes, that's what we have seen as part of the period that if people kept together, the risk of infection is higher. But then we're bringing in the issue of compulsory masks for everybody, and also compulsory sanitation and all of those issues to actually reduce the risk with all of these factors in mind. And so we will find as we move on that there will be proposals where there might be contradictions, there might be what appears to be inconsistencies, but they're all in a view to try and manage a situation which has been caught in a difficult situation of controlling the infection, trying to run normal lives whilst at the same time trying to reduce the infection. So it's not going to be possible that we will always get perfect answers. So for those who might feel that some of the issues are not perfect fits, that's because that's how life is and that's how managing COVID-19 is. We're not going to find a perfect answer for everything. And the perfect way of stopping the infection from spreading is to get everyone to stand or to be on their own and not mix with any other people. That is the best way of doing it, but it doesn't, it's not practical, it's not possible, and therefore when you start introducing the activities, social activities that we need to conduct our normal social and economic lives, then of course you have to start dealing with choices, options, and compromises. That's a very difficult issue that we have to deal with under the circumstances. So I think we need to just understand that if anybody thinks that we're coming with solutions that are not perfect, are not 100%, we will admit that they may not be. But that's the best effort that we can give to try and deal with a complex situation. We may not be able to get the numbers to be as low as what we would have wanted them to be. But we have to understand that what actually pushes the numbers up, is the fact that we have got to try and adjust a lot of things together to try and make South Africans continue to live a life, but at the same time try and manage the situation. So it's a very difficult issue to have a perfect answer that will say it does not subject itself to being questioned or people having different views about it. We have accepted that there might be many instances now where we will take a decision. If you took that decision, you will be doomed. And then if you didn't take that decision, you'll also be doomed. And therefore, we have to understand that it's the complexity of the interest in society, as well as the challenge of having to deal with a situation that no country really has ever faced before until now. And because of that, there will always be weaknesses in some of the proposals that we'll come up with. And when those get pointed out and we can find a way to solve them, we'll solve them. And some we may not be able to do anything about them, we may not be able to change them. So that's the reality that we must understand. And also when people go out there and raise issues and criticize what decisions government would have taken, in some cases it becomes helpful because you learn something. In some instances, with the criticism, it still doesn't help to bring a new solution. So I would propose that when people raise the issues, they need to take into account all the factors that we've taken into account, and then when they come with a solution, we're able to evaluate to what extent that is actually helpful for us to be able to consider those kinds of views. I don't believe that we can be unable to pick up a positive suggestion when it actually becomes helpful in the process. The shortages on the staff, on the health workers, it's a historical issue. We've always had this as a challenge, and part of it has got to do with the fact that over the period there's been constraints in the resources, and so there were a number of posts that were frozen over a period, and that has caused that there should be shortages. We've actually gone out to a number of provinces to encourage them to open up and employ more people, and a lot more staff has actually been employed. This morning we were actually bringing to 4 hospitals in Gauteng staff that we have procured as the National Department of Health and given it and gone to the private sector nurse recruiting agencies to actually go and make sure we close the shortfalls in the various hospitals. We will do everything to try and find additional human resources to cover the gaps, particularly because we do know now that a number of instances people do stay off work because they're in quarantine. I was in Steve Biko academic last week and I was told 120 of the people have been infected. We've got throughout the whole country over 4,000 health workers who are infected, and some of them have recovered and so on. But the point is that we do need to employ more of the nurses. So the opening of the colleges that we announced earlier this year, nursing colleges, we also we've been discussing with the various provinces to also negotiate with some of the private colleges, nursing training colleges, and give them placement in some of the public hospitals so that they can actually increase the numbers of nurses who get to be trained at that level. So we believe that those are some of the ways. Now, there are databases which we have also been tapping on. For example, in Gauteng last week, they reported to me that they were able to get about 1,300 people off the database who they thought could be easily employed, and we've said to them, go ahead, employ all of them. And in the process, part of those that we're talking about right now that came from the nursing agencies are part of the group of nurses that we find as we go all out to look for additional nurses. To fill in and train over 12,000 nurses obviously is a process that will take us a while, and certainly we have to up the numbers of the people who are being trained out there, and it also depends on the various categories that we have to look at. Last week I also announced that we had to release from training some of the nurses that we had sent for training to bring them back to service. Probably about 370 or so of those to come back and join in the service so that they can assist in improving the numbers of nurses that are available. So we will continue to work through looking for additional nurses and also emphasizing on additional training so that we can ultimately get those numbers satisfied. Obviously, numbers of nurses that might be needed is a moving target, because as soon as you will have trained those 12,000, you'll have retired a number of them as well. And so it becomes a number that keeps moving. And at the same time, we have also got our human resource development strategy that we have said Professor Rispel, who was leading that team, need to look at not only what we were using as the human resources from which there were vacancies, but we must start looking further ahead in terms of what our future requirements, in terms of the increasing population size, the national health insurance situation that we're going to be taking into account for the future. All of those issues need to be taken into account to say, what do we need as our human resource development program going to the future, what numbers, what categories, and what level of training, what other conditions need to be so associated with that. So it does become a bit of a broader issue that COVID-19 has put a strain on a lot of our services in terms of our infrastructure, in terms of our staffing, in terms of our supplies of oxygen and other equipment, PPEs and so on. It's put a huge strain because of the crisis that it has posed. But nevertheless, we are going to be solving those issues as we move along. And we believe that our determination to succeed and defeat the COVID-19 is a lot more important, and therefore we always call upon South Africans to work together with governments to make sure that whatever challenges we face, we're able to overcome. Thank you very much.
Thank you, Kawazela. Let's take the last round. That will be 15 questions.
So the last 5.
How many do you have?
I have 10.
Okay. Let's just so that people don't say, can colleagues let me now do consultations? Kabazela, Namakeba, can we take all of them? Let's take all of them. I think there are some that are for Umamle. Are they all for health?
They're all for all of the remaining questions are for the Minister of Health.
Okay. Nice. Oh, you got a question on your system?
Yes, it's just one that arises from something that you say.
Izake udile ngayo ke sisi, then let's say we then take those ones.
Thank you, Minister Mthembu. There was just one question that we got about the basic income grant, and that was from 702, ne? Stephen Grotes, yeah. It's about us explaining whether the basic income grant we are confirming that it will be done or not. I did explain that it's been on discussion for a very, very long time, and one of the experts of it is actually sitting in this room, who came to the Department of Social Development long before I came here, Brenda. And we discussed this issue very lightly last year, simply because we're looking at what were the options that could be presented for us to cover millions of our people who actually struggle. As we said, it was between the ages of 18 and 50, ne? 59, yes. We were looking at those people who were getting lost in the gap, even with our own social grants that we are already giving as a social safety net. Then COVID obviously happened, and then we were propelled, and we still propelled even now, to start looking at what options do we have on the table. So we are now exploring what options do we have for us to implement the basic income grant. And by the way, may I say, this issue is not new, to a point that the portfolio committee chairperson and the portfolio committee, in fact, did invite those that penned the Taylor report to come and make a presentation so that we could take a step back and say, how else, what other interventions can we have to respond to COVID-19, but not only in the short term, but also in the long term, because again, the issue of poverty, hunger, and unemployment is a big problem for South Africa. So we are looking at post-October, because the president announced that we were only going to be able to pay the 350 grant as social relief of distress for a period of 6 months. And we already started thinking, well, then after 6 months, then what? People shouldn't be asking us that question, and we've got nothing to put on the table. That's our responsibility to start talking about it. So we are engaging, as I say, the Taylor report was presented, for instance, to the portfolio committee. And what was good about the Taylor report is that they now looked at the work that they had done before, but they were also looking at COVID and the impact of COVID, and therefore what they think we should done. we're looking for alternative ways to phase in over time what we are proposing. And may I clearly say that this will cost a lot, it costs billions, but we need to be able to say, what do we do to cushion our people who are in between, who actually can be able, provided they have something in their pocket, they can take care of the family, they can also go out and look for jobs, they can also access other things. I mean, right now we're talking about people working only from home, so even the movement of people is very difficult. People need to be creative towards the future. What kind of an economy do we want in the future? We're therefore looking at alternative ways to phase it in over time. The amount that should be provided, the funding options, potential economic impacts and sustainability considerations are also very important. At the same time, we do want to say as a department that we are very conscious of the public purse. We are very conscious of the fact that the Minister of Finance is struggling to get the money. We are all conscious of that, but we're saying, as South Africans, I'm sure we can come together and have a discussion about this, because if we help our people to help themselves, it will be better for the future. So the discussion is ongoing. Most parties, even in the portfolio committee, were kind of like saying, this is a good idea, let's talk about it, let's discuss it, let's see how far we can take it. When all is said and done, we're looking for options to help our people so that the poverty and the hunger that we see every day is eradicated completely from South Africa. And we also, at the same time, looking at that, we're looking at other programs. You know, there are programs of the EPWP programs where people have to go out and work. We're also looking what else can we do so that people just don't think, okay, government is good, you're going to give us the basic income grant, then we're going to just sit at home and do nothing. I don't think people would find the basic income grant itself as adequate, but it will be a leverage and something for them to use to go looking for other opportunities. Thank you very much.
Let's then get the remaining questions, Nanga, and then don't allow any.
Okay, can I just 2 seconds?
Has your laptop frozen?
No, it has not, Minister. No, it has not. Okay. Miriam Issa from Finweek is asking to the Minister of Health. You have said in a recent speech that the projections for fatalities in South Africa are now lower than the most optimistic scenario models at the beginning. Can you provide us with the latest projections and tell us why they are lower than initially anticipated? Paul Vigiato from Bloomberg is asking, when will nationwide testing for COVID-19 antibodies begin, and what is the minister hoping that such a test program will prove? Then Vuyom Voko is asking, it's related to the question on the taxi, the 100% capacity of taxi loads, is basically saying that, Minister, there can be no social distancing in a 15-seater carrying 15 passengers. Is government in this instance not simply capitulating because you don't want to be at loggerheads with the taxi industry and given its reputation? The fourth question, it's from Tamar Khan from the Business Day. Can you elaborate on your remarks about changing the time period for quarantine and self-isolation? What is the scientific basis for this change, and what will the new period be? And Nazir, the fifth one, Nazir from Glow TV. Whilst it is acknowledged that most health workers in hospitals are performing an excellent service, there are reports that certain COVID-19 patients, especially the very ill, are virtually left to pass on. Given that family members are not allowed to visit their loved ones in hospital and have no idea what is happening behind closed doors, what mechanisms are in place to ensure that the utmost care and treatment is given to patients to the very last by the overworked hospital staff? Nazir is also, it's not really a question, it's more of a comment, I think. Can you please release general information updating us as to how COVID-19 is spread, given that it is also airborne? For an example, some people believe that the virus is spread via exchange of money in terms of coins and notes, etc. Others believe that the virus does not live in the body once a person is deceased. Thus, many religions have still washed the body of a COVID-19 death. And others say that it can spread via air conditioners. Number 6. We hear daily of procedures not being followed in medical settings, including transport pool vehicles of state hospitals used to transport staff, and is also used by contact tracers, not being sanitized between different workers using a vehicle. Is there any facility for people to report this without fear? Without fear of reprisals from their managers? Lizeka at News 24. Some publications, this is number 7, some publications have raised the ethically fraught issue of health workers possibly needing to make decisions of just discharging patients from ICU beds or ventilators to make way for other patients with better prognosis owing to limited resources. Have there been discussions on how these decisions will be taken and how these limited resources will be shared? Number 8, this is a very long question. Many people who are over 60 years old are still working, despite government saying that those over the age of 60 should stay at home and employers should make arrangements for them to work from home. This includes teachers and health workers with comorbidities. They have filled in forms but are still waiting for a response from the head office. In the meantime, they have to risk their lives going to work while many people are testing positive around them. What is the process some workers over the age of 60 should follow should they not feel comfortable to continue working? This is despite having filled in forms stating their underlying conditions to their employers. Number 9 from Bonga Dlulane. Oh, this is actually directed. Bonga Dlulane at EWN. It's directed to the Minister of Social Development. The special COVID-19 grants ends in September. Since there's been issues of non-payments and delays, does this mean that come 1st November they'll still be cut off, or are we making other provisions? And number 10 is from Tabo at ETV News. Can the Minister of Health measure and give feedback on how the ban of cigarettes has assisted in curbing the spread of the virus, and how effective the ban has been in avoiding the said sharing of cigarettes? Thank you, Minister.
Yeah, that was a long play by Noneba of questions. What was it? What was that for?
Thank you very much. Thank you very much. When I was a student, we used to have a set of questions we used to call MCQs. They were so long, and you had no choice but to answer them all. The consolation was that if you did, you'll get your certificate. This time around, I have to make sure that I got them answered. There are one or two questions that I won't be able to answer because of the kind of nature of information that they are looking for. I'll deal with those as I come to them. Well, I think the first one relates to the question of optimistic scenario in the modeling. Can you provide the latest projections? That one requires us to go through graphs and numbers, and I think it would be fair to say if I can get the details of the particular individual, we can then send them the information so that we can talk about it. But we have a consortium of modelers who have been feeding in a lot of information and tracking and looking at what up to now has happened compared to the previous models that they've given to us. They've been able to establish that there's a difference in the pattern of what happened in the model that they provided compared to what is happening now. And so those numbers, they've actually worked, they've been tracked much better in the Western Cape because the surge came out there much earlier. So we were able to see that the numbers of admissions that we expected, the numbers of people who had passed that we had expected were not quite the same as what we're seeing, what we're seeing now. And so this was actually worked on for various provinces, and so we need to then show the graphs and the numbers. I would love to get the number of the person who has asked, Marian Isa. If we get the numbers, we'll then try and send them the specifics. The Paul Vecianto from Bloomberg is asking about the antibody tests. We have left that matter for the ministerial advisory committees to kind of finalize between themselves and the South African Health Products Regulatory Authority to give us the best a set of antibodies that can be completely validated, but also still be available across the whole country on the basis of the global supplies, so that we could start looking at using those antibody tests. But I must say that there's been a lot of discussion. Most of the medical experts have actually not encouraged the use of those antibody tests. They've only encouraged us to use the PCR, which is a direct detection of the viral bodies or particles, so that that's the test that we use. However, if we had these particular antibody tests and they were validated, they would also only indicate whether someone had been exposed to the infection or not, and that's what the value thereof would be. And I think as the numbers are increasing, if you want to check in the community to what extent people have been exposed, they would be actually very useful, particularly because at some point you will notice that there are many people who may be positive, who may be infected, but will not be tested, and then they would have been positive in the process. So it would be an interesting one. So we continue to work on that. Vuyamvogo is asking the question about the taxes. I have actually tried to clarify this again before. There wasn't an issue of capitulating in this regard. We had a thorough discussion with the Department of Transport to look at what the issues are, what the possibilities are. Even as we discussed, the minister had actually raised the comments that had been brought up by the taxi industry, that they would in any case go ahead with whatever load levels that they were talking that they were talking about, that they would insist on 100%. Actually, once we had sat down and met with them, that matter got off the table. They were actually prepared to understand what we were raising as the real concerns, and when they understood it, then we were able to try and approach the matter from a point of the objective information that we had available. So there hasn't really been any question of capitulating in this matter. And the first instance when the matter was raised, there was quite a standoff between the Minister of Transport and the taxi industry, and they tabled their issues, which were tabled to the National Coronavirus Command Council. Then we were tasked, myself and the health teams, to meet with the Minister of Transport and evaluate the issues that were being put on the table. Having done so, we then called on the Taxi Association. We went through with that discussion. Actually, what really made the leaders, both in Santaco and the NTA, to understand the issue was when we took them through the presentation, which was led by Professor Abdul Karim, to show them where the problems were. And at the end, they were actually quite appreciative of the issue. So there wasn't much of loggerheads in the way we dealt with the issue. We had to provide the best advice and solution the best we could under the circumstances. That's why I raised the question that there is nothing perfect here that we're going to find. We're going to find in situations where difficulties are going to have to be confronted and contradictions are going to have to be faced, and that at the end there may be solutions which may not be consistent, from one setting to the other, but we really try to do our best in this case. So I must say, when we ended up with that discussion, the Taxi Association, the whole executive, all the executives who were there, they were pretty understanding insofar as these issues were concerned. And when we discussed with them, there were quite a lot of issues that were put on the table to say, these are the options and possibilities of what can happen. We'll leave the matter to the National Command Council, and therefore we will come back and indicate to you what happened. That's why I think when the President made the announcement, then everyone went back. They were saying they'll go back and go and discuss it and then come back and respond. I haven't been certain as to what response they would have given, but at the time we're discussing it, it was quite clear that our approach to explaining the dangers, the risks that are associated with all of the issues on COVID-19, they actually understood it better. And I think it has actually improved their approach in terms of how to cooperate as we ask for particular conditions to be imposed in the way the taxi industry is run. Tamar Khan raised an issue about the period of quarantine and isolation. I just indicated that we are in the process of reviewing it. We're not in a position yet to announce it. So as soon as that is done, we will then be in a position to announce that. So we will come back to her as soon as possible on that, as soon as that matter has been sorted out. The next question is an acknowledgement that health workers are doing an excellent job. I'd wish that we could leave the question at that point, because I think we haven't, praised and thanked and appreciated enough the work that's being done by the health workers, because they are actually the backbone of this whole fight against COVID-19. Nevertheless, the concern that is being raised here is a natural concern that arises when we have a very difficult situations where the families are not able to visit their loved ones who are sick in hospital. It's a very painful situation actually to be sick and you can't be meeting your parents, your friends, your members of family, because the issue is they may not be able to take away the disease, but just the fact that they are there to give you support is a huge contribution to the healing process on its own. That's why we visit people to their homes, we go and see them, we pray for them, we bring them flowers, we talk to them and encourage them, because part of the healing has to be about the willingness to fight, the readiness to confront a difficult challenge that is maybe uncontrollable within your body. And so I think this concern is a concern that I had a discussion on this matter yesterday with the MEC of Gauteng, and we're saying, if there was a way that we could actually even open up space for people to be able to text and send messages home and so on, because sometimes I receive messages of people who are saying my parents, my parent or my mother or my uncle or my father, who there's this and this happening, and you respond to those, but you realize that there is a very strong need for relatives to be in touch with those who are sick. We will continue to do our best to monitor. Our supervisors, our managers, have a responsibility to ensure that the best care is given to the people who are in hospital. And if we ever pick up anything that's untoward in the way anyone would have been treated, we institute an investigation immediately. Sometimes all we get is an SMS. Sometimes you see somebody posted in a WhatsApp, in a tweet, somebody posts in a Facebook. If we pick any of those up, we go straight and go and deal with it, although it's not the normal way of how we take up complaints, but we are understanding that there's a limitation towards anybody coming forth and reporting that there was something that was not, properly managed amongst the patients in the hospital. So we will continue to look at various other ways of how to improve communication, because I do agree that it's impossible for any of us to go visit the people in the hospital when there's COVID-19 because of the nature or the infectious nature of the disease. But at the same time, it's also difficult to have someone who is sick and you cannot deal with them. You can't phone them and you sit in the house worried, waiting. You phone through. Somebody sent me a message and quoted to me how many times they've been phoning through asking for someone to answer the call. And I do understand as well with the staff, because the staff, they're dealing with very sick people. Now, there's a call now, please answer about so and so. When you put it down, there's another call. When you put it down, there's another call. And at the same time, there are patients who are calling, I'm hungry, I need food, please cover me, please give me pain tablets and so on. It's a very, very difficult situation that we're dealing with. And so I do appreciate the fact that all of us are understanding of the difficulty that we have to face in this regard. We'll continue to work in this case. We do also accept that our staff is, working very hard, and we do appreciate that work. We will plead with them still to continue to do the good job and look after the people with the care that every one of us expects when we get to the hospital. The question is about, I don't see who says it, but they say, given information about COVID-19 spread, given that it is also airborne, for example, people believe that it can spread on exchange of money, and that if somebody is deceased, many religions still wash the body, and that it can spread via conditioners. Now this is like 4 questions together. The first one is about money. We have raised the issue with our Ministerial Advisory Committee to check on this. They haven't found evidence anywhere that says that COVID-19 can be spread through exchange of money. We're asking this in relation to the way in the taxis people actually move money from one person to the other, but we've said that the taxi operators must decrease the exchange of money just to make sure that we limit whatever risk, but we don't have evidence that that's what happened. The washing of the bodies, we have actually restricted that washing of the body of someone who's died of COVID-19 to professional services of the funeral parlors, and out of that we have also discouraged anyone from from opening up the bodies and washing them up again in at home. We've also issued guidelines about how the bodies must be viewed and how people must stand from a distance. The idea of touching the body, kissing the body, and all of that is really out in the case of COVID-19. And so we will continue to spread that message. That it can spread via air conditioners. This actually is something that is seen to be a possibility. Among some of the cases in China, in China, where the spread was noticed amongst what were they called the super spreaders, one of them was actually a patient that the only explanation that could be given was the fact that the person had come from Wuhan, sat in a restaurant, and then where they were, a few people got infected, but then they started getting infection when people were sitting in nearby tables, and they only figured out afterwards that it was the flow of the air from the air conditioner that could have been a factor in this matter, and therefore we discourage the use of air conditioners now in many instances, and try and ask people to use ventilation using windows so that this can be reduced. Then the question of state hospitals where the vehicles are used for tracing as well as for staff and not being sanitized in between. I think we just need to make sure that we send a reminder that there must be decontamination of vehicles so that this fear should not be an issue. But the report, anyone who wants to report does not need to raise it with the immediate supervisors if they are concerned, but they can write the letter to their district office, to the MEC's office, or to the head of department, to the minister, so they can report those issues so we can follow them up. So they mustn't fear. In this case, when someone is worried about anything in relation to COVID-19, no one must fear victimization. Report where you think you can get someone who can, send your matter through. We're picking up reports coming from different people simply because there are those who might be, unsure whether it's safe to do that. But no official, no manager has got a right to intimidate or to punish any person who reports anything that's a transgression in terms of the infection prevention control measures. And therefore, we would encourage people to report when they find such situation. Then the ethical issues of patients who people have to make decisions, workers have to make decisions of discharging patients from the ICU or ventilators, make way for other patients with better prognosis. Well, I'm not sure where that comes from. I haven't really been informed that there is such a crisis, but what I can say is that the management of patients is in the hands of professional nurses, doctors, and other health professionals. They have to evaluate the condition of the patient and the necessary intervention that is needed, and whether in fact if someone is on a particular form of treatment, whether continuous usage of that is still helpful for the individual, and they'll have to make the call. I believe that that is how we must leave it, because it's a professional call, and all that we would want to do is that where there is need for additional resources, we need to then be informed. Again, over this weekend, I was contacted by one clinician. I have not met him, but he managed to get hold to get a message to me and indicated what their concerns were. Sitting where they were concerned that the availability of oxygen is something that they would like to move pretty quickly on, but they were not sure about the procedures within the management structures and so on. We simply pick the issue up and then assist to make sure that the managers, if they miss an issue and someone else picks it up, we then go and assist that the clinicians on the ground must always be empowered to intervene and assist people. And in this case, I would say there are limited resources, but we have to rely on the judgment of the health professionals who are managing the patients, and that together with them we will look at where the constraints are and try and improve the availability of those. Then Pel Makubane, SAPC, asking about those people who are over 60 years who have sent letters and have not got filled in the forms and have not got the response from the head office. I think we just need to encourage, urge the management to respond to these particular issues, but these may be teachers and so on. So I think we just need to encourage the management in the education department to respond as soon as possible so that people can be dealt with. In some of the instances, particularly amongst the health workers, we've actually said that not everyone needs to go to the forefront. Some of them can actually work as advisors on call centers, where they would be in a situation where their experience and their many years of working with individuals, they can make a quick assessment and therefore advise people. It's still very, very important at that level to guide people, to advise them, to direct them where they need to go. So that we will encourage that where people need to be brought onto the service, then they would need to be put into areas where the risk of themselves complicating with a new infection is less, and their value and their experience can still be tapped. The last one, the ban on cigarettes. We need a feedback on the ban of cigarettes, how it has assisted in keeping the spread of the virus. We're not ready with such information. I'm going to ask our experts and researchers if they've got such information, and therefore we can respond to those who have asked the question. We're not, I don't have any direct information that such a study has been done. I will check that up. Thank you very much. Thank you. I hope I've covered as much as could be done. Thank you.
Minister Zulu, your one question.
Thank you, Minister Mthembu. Yes. The question was about if you applied and you did not get a response, and then you get a response, will you be paid from the time that you were approved, or will you pay from the time that you applied? You will be paid from the time that you were approved. If you were approved as way back as May, we've paid all May anyway. If you applied and you were not paid for June and July, we will pay you retrospectively, because we have to pay you from the time that you were approved. And I think the CEO did deal with the steps that need to be taken by those who have not been assisted. Mthembu, if I may, I just want to leave one more message to our people as a plea, really, that COVID-19 iyaphila. Hle ihlokomeleng, hlokomela balilapa, re kgone ho hlokomela South Africa yotle. So everyone must just take their responsibility individually, family, community, home to home, street to street. If that can be done, I am sure that as South Africa and as a nation, we will rise to the future, because we cannot run away from our own country. Please, just let's all take care of each other. And in our department, SASSA, NDA, and the department, we see the numbers also rising And I wish to also say to the frontline workers, as Minister Mkhize said, the doctors, the nurses, the all. I do also want to mention the fact that people that we work with as ministers, they are also frontliners. They wake up in the morning and have to go to one place or the other. And they are also just risking also as they step outside of their homes. But I'm sure that these are people who've committed themselves to helping the nation, and we will continue to serve the nation in the best way that we can. Thank you, Minister Mthembu.
Khabazela ngiyakubona ukuthi nakunento ekushisayo ungaya lapha before ngivala lombhala lomhlangano. Khabazela.
Thank you very much. I see there's another question that was sent by Sophie Mkwena from SABC asking about Russia has been reported to have discovered a vaccine and wanted to know if we are aware of that. Yes, certainly we have heard of this, but it is not discovering a vaccine, but there are many vaccines which are on trial at different phases in the whole world. There is one that's being done here in South Africa, which is one phase where South Africa, the UK, the US, Brazil are also all participating. But there are a number of other trials which are at various phases of development. What we understood in this case in Russia is that this is a trial that's gone through one phase, and out of that phase there were some volunteers who were going through that, and the whole phase went on very well, but it does not mean that there's a complete success as such. It means that they're still gonna go to another phase of being another phase of the trial. So it's just different phases from what we understand has happened in Russia. At the moment, we're not aware of a country that's got a successful vaccine that is now ready for use, that can be used. But we are aware that vaccines go through various phases, and there's a first phase and the second phase, and in this case, looks like that's what we're talking about. So that's the extent to which we are aware of the matter. But we are not aware of a country that has completely completed the whole cycle of development of a vaccine. Thank you very much.
Colleagues, I would like to thank you very much, Khabazela. Thank you very much, Makeba. Sibonge kakhulu siswami. Also, I would like to thank the listeners at home, because the reason why we are here is to give as much information as possible so that all of us can be party to the war against this enemy that we cannot see. But this enemy called COVID that has infected so many of our family members, so many of our communities, and indeed that has killed so many of our community members and so many of our family members. There was a time, Khabazela and Makeba, when it was just anecdotal that there is COVID because you could not touch it. Now nobody has been spared, no family, no community. All of us, even in our workplaces, people that we work with, who have lost their loved ones, we have lost our loved ones, people that we work with that have had to be quarantined. So we now know from experience that this thing iyaphila. Lento kuthiwa yi-COVID ikhona iyaphila. And again, we would like to say to our communities, let's just do the best that we have got to do. And we have said from early in the morning, let's wear masks. We have said to this afternoon, let's ensure adhere to social distancing protocols. Let's wash our hands. Let's wear masks everywhere where we are, in our shopping malls, in public places, because at the moment, as Minister Mkhize has said, the only way we have to deal with this disease in the absence of a vaccine are these protocols, nothing else. So there is nothing that we have to protect ourselves, to protect our families, to protect our loved ones. And of course, in the regulations that we spoke to earlier on, we even said that we also have regulations that are meant to protect our loved ones, so that we don't go to visit our families and infect our mothers, our fathers, our grandmothers, our grandfathers. That's why family visits are disallowed for very good reasons. But again, a lot has been said about why we have said, let's not open again for the sale of alcohol and for the drinking of alcohol, as the minister has said, because the impact thereof will basically overwhelm our health system, and indeed people that will be at a serious disadvantage are people who are infected with COVID. They will not have the beds that we need for them to be treated, at times even quarantined in our hospital facilities and our health facilities, because those beds will be taken by people who have been involved in accidents, people who have been stabbed, people who have been shot, all induced by the taking of alcohol or alcohol consumption. We know. We know, at times we don't say these things. We are bad drinkers as South Africans. Our impela sizidakwe ezimbi. Singabantu base South Africa. Khona abanye abantu abakwazi ukuphuza nje ibhodlela baliyekele baze baliqede after 2 months. Thina silishoye within seconds ibhodlela. Asidlali ngalo. Nalo thina silishoye within seconds singene emotweni. Siyoshayisa abantu. Or siyoshaya nabafazi, yes. So we are very bad when it comes to drinking. And as Minister Uzweli has said, during the lockdown, there were so many few incidences of people who came to our health facilities because they had been involved in car accidents, because they had been shot in shebeens or taverns, or they had been beaten up by their husbands in their homes. There were very few. But immediately we opened under level 3, hallelujah. It was so bad, so bad. By the way, a lot of people have been asking us, why did you open? That's what we were asked, wherever we're going. In the first place. So we are saying that we are doing all this to save lives. We are doing all this to ensure that we will have life even after COVID. We don't know when that after COVID will ever come, or we must prepare ourselves to live with COVID forever. But as we do so, we take into account all these health protocols that we have spoken to. So, colleagues, thank you very much. And also thank you to the SABC crew who have been here from early in the morning, our colleagues from departments, and also for the other television broadcasters, your ETV and Newsroom Africa. I know that they've been carrying this live as well, taking the feed from SABC. Thank you very much. And people at home in particular, Siyabonga, and also those who are from our offices who have assisted us, our CEOs, our media officers, our chief of staffs, our PAs. Thank you very much. Siyabulela. This meeting is adjourned.